Today we are going to talk about the core concepts related with the edema, right? Now, before I really give the lecture, I would love to ask you a few questions. How do you define what is edema? Yes, please.
It is the accumulation of interstitial fluid in the body tissues.
Right. She is saying that edema is accumulation of interstitial fluid. Interstitial fluid is normally there. Interstitial fluid is normally there, but normally we are not edematous. Someone can improve on this definition? Yes.
So accumulation of abnormal fluid in the interstitium.
It's really, we can say, you are saying that it is accumulation of abnormal fluid in interstitium. Still not good. Yes, Izaz, you can make it a better?
Accumulation of abnormally excessive fluid in the interstitium.
Okay, he's saying that edema means accumulation of excessive fluid in interstitium. Right, this is right definition, but it's not the complete, because by this definition you miss a big part of edema. Anyone can improve it further? Definition of edema, yes.
Abnormal accumulation of fluid in the interstitium.
Abnormal accumulation of fluid in the interstitium, yet not, yes.
Due to increased capillary permeability and increased hydrostatic pressure.
Okay, anyone else?
Excess fluid inside the cell or outside the cell.
Excellent, very good. He is saying excess fluid in the body, there is excessive fluid either inside the cells, which is intracellular edema, or in the interstitium and body cavities, which is called extracellular edema. So my dear friend, at least you should know what is edema. Let me tell you, edema is excessive fluid. Excess fluid in body tissues, that's it. What is edema? Edema is excess fluid, yes, in body tissues, that's it. It may be intracellular or edema may be extracellular, right? When you say edema mean fluid in interstitium, that is wrong, because normally there is fluid in interstitium. And if you say edema is excessive fluid in interstitium, then you miss intracellular edema, right? So what is edema? Edema simply means excessive amount of fluid present in the body tissues. But let's refine it further. Why? Because it's excessive fluid not in all body tissues. For example, if there is excessive fluid in the blood, is it called edema? No. If there is excessive fluid in the blood, that is not called edema. It means that whenever there is excessive fluid in the vascular compartment, that is not considered edema. So we can further improve our definition that edema is excessive fluid in body tissues extravascularly. Extravascularly. Right? Now let me draw a diagram to make it more clear. Let's suppose from your body I remove a piece of tissue, right? This is a piece of tissue, a typical tissue from your body, and naturally this tissue is having arterial supply, right? Let's suppose here is your left heart, right? Systemic circulation, and this is, hypothetically we make that there is arterial supply coming to this tissue, right? Arterial input. In the same way, this tissue must have some outflow mechanism, that is venous, right? And that will be going to which side of the heart? Yes, please. Right heart. Very good. That will be going to the right heart. And of course, all of you know that blood from the right heart, yes, blood from the right heart to the pulmonary, what? Arteries go to lungs, and through the microvasculature of the lungs, blood is eventually being drained to the left side through pulmonary veins which have oxygenated blood, right? Now what I'm showing in this diagram, from the left heart blood is going to the tissues, right? And we have taken a sample tissue here and this is the arteriolar input. And here I have shown the venous output. Is that right? Now, let's see in detail in this tissue, right? Arterial system, of course, arteries come, they divide into arterioles, and eventually they divide into capillaries, right? This I'm going to draw microcirculation. This is your microcirculation, this one, right? And there is arterial input, here is venous output. Here are your cells in the tissue, right? Parenchymal cells. And let's suppose this is representing body cavities, right? Body cavities, these are parenchymal cells in the body. And this area, this is interstitial tissue. What is this? Interstitial tissue. So we can say interstitial tissue is between the parenchymal cells and the vasculature. Is that right? This is interstitial tissue. Now, let's divide our body weight and see what are the normal fluid compartment. Because when we define edema as excessive fluid, we define edema as excess amount of fluid in body tissues, but extravascularly, right? When we define like this, we must know what is the normal amount of fluid in different body compartments, right? Because when fluid is excess, then it is edema. But as a good doctor, you must know what is the normal amount of fluid in different body compartments. Let's suppose here you are, your beautiful picture, right? Yes, let's suppose you are adult and your weight is 72 kg, right? If you are 72 kg, how much water will be there in your body? Yes. 5 liter water. I think I will die immediately. 5 liter water is too low water. You know, if you are 72 kg and if you have only 5 liter of water in total body, you must be dead already. 1%, yes. 42 liter. How did you calculate it?
60%.
Excellent, very good. Actually, when we say total body weight, right? 72 kg is the total body weight of this person. Total body weight is divided into two: total body water and lean body mass. Lean body mass and total body water. If we remove that, for example, if this diagram is representing all the body weight, right? If it is representing all the body weight, then in this person, this whole should represent 42 kg. Out of that, total body weight divided into lean body mass, which is about 40%, and total body water is about 60%. This is very important to understand. Whatever our weight, approximately 60% we are just water. When we say, if I say I'm falling in love with a girl, actually 60% water of Dr. Najeeb is, and plus 40% of lean body mass is falling in love with the girls. How much water? 60% of the water and 40% of lean body mass. So you need to remember this, that all of us consist of about 60% of water. About 60% of water. Is that right? Children have a little more percentage. Anyway, so 60% of water, it means if my weight is 72 kg, then, okay, this whole system has 72 kg weight. How much water? 60%, about 42 liters. So if my weight is 72 kg, I will have how much water? 42 liters. Don't sell 42 kgs. And if my weight is 100 kg, then how much water I have? 60 liters. So is that clear? Yes. Right? And out of this 42 liter is divided into very important fluid compartments in the body, right? For example, out of this 42, 1/3 is in the intracellular fluid. It means 1/3 fluid is present inside the cells. These are cells. So all your, if my weight is 42, yes, 72 kg, total water I have is 42. Out of that, intracellular is 2/3 and extracellular fluid is 1/3. Extracellular is 1/3, intracellular is 2/3. And what is extracellular fluid? Extracellular fluid means outside the cell. Outside the cell means fluid in the interstitium, including body cavities, and fluid in the blood. You are understanding? So if I have 72 kg weight, there are 42 liters water in my body. Out of that, 28 liters is present inside the cells, because 42, 2/3 is 28 liters, and 1/3 is 14 liters. So it means I will write it here. How much I have? 28. 28 liters here. And how much is left then? 14. So 14 liters is here. Outside the cells. Out of this 14, inside the plasma is about 3.5 liters. 3.5 liters. And outside is about 10.5 liters. Approximately. Of course, the degree of hydration changes person to person and time to time. But approximately, now we come back. So what we have decided, that extracellular fluid is divided into interstitial fluid, which is here, and what is this? Intravascular fluid. Normally, how much blood you have? How much blood you have? 5 liters. You were answering this thing. You were saying 5 liters. 5 liters is the amount of blood in a person. But we have fluid outside the blood. Secondly, in the blood even 5 liters is not the whole fluid. There are cells too. We are talking about, let's suppose this is vascular system. These are red blood cells. Now, which is the fluid inside the red blood cell? That is intravascular. Not only intravascular, that is intracellular too. In the blood vessels, you have 5 liters of the blood, but in the blood there are cells, right? And there are red blood cells, there are white blood cells, and there are platelets. All of them have fluid inside, but that fluid is considered part of the intracellular compartment. That is considered part of the intracellular compartment. So plasma which is left, that is considered extracellular. So plasma is about 3.5 liters. Out of 5 liter blood, 1.5 liter you can see is your cells. Cells. My friend, you are having 5 liter blood, right? Out of that blood, approximately 1.5 liter is your cells. And whatever fluid is present inside the cells, that is considered intracellular fluid. Is that right? But other than cells, blood has plasma. So 5 liter of the blood, 1.5 liter is cells, and 3.5 liter is plasma. That 3.5 liter plasma is considered part of the extracellular fluid. That is considered part of the extracellular fluid. That is why extracellular fluid, I write 3.5 liter here, and remaining is in the interstitium and very little into body cavities, right? So interstitium approximately 10.5 liters, right? So this is the normal distribution of fluid. Why I'm teaching you normal distribution? Because in edema there is abnormal distribution or excessive accumulation of fluid in extracellular or intracellular component, right? Now let me repeat. If I'm having 72 kg weight, right? Lean body mass is 40% and total body water is 60%. Out of that 60% total body, right? Okay, let me put it that we are having, this is total body mass, right? 40% we remove, what was that? Lean body. Now what is remaining? 60% is water. Now out of that water, intracellular will be 2/3 and extracellular will be 1/3. Is that right? So intracellular out of 42 will be 28 liters and extracellular will be 14 liters, right? And this extracellular fluid further divided into interstitial fluid and plasma. Is it clear? Any question up to this? Now why we were studying, let's suppose interstitial fluid in total body, rather than 10.5 liter, it become 20 liter. Then it is generalized edema. Or in a specific tissue, in a local area, interstitial fluid is excessive. Now, before we go into further detail, let's go to the very basic, right? And we have talked about that, again I will repeat, that edema is excessive fluid in the body tissues extravascularly, right? So this is the definition of edema. And edema can be divided into now two types of edema: intracellular edema, which is this edema. If there is excessive accumulation of fluid inside the cells, that is considered intracellular edema. And if there is excessive accumulation of fluid outside the cells, what is that? Extracellular edema. Extracellular edema, and here it is intracellular edema, right? So today onward, when you talk about edema, please clear that are you talking about intracellular edema or extracellular edema. But in medical literature and during medical discussions, generally speaking, when we say edema, usually we mean excessive fluid in interstitial area, right? So if excessive fluid is here, what is this? What type of edema? Extracellular edema, or in general discussions, non-specifically speaking, we call it just edema. We just call it edema, right? Excessive fluid, intracellular edema, excessive fluid here and in body cavities, both are called extracellular edema. Am I clear? Now, what are these body cavities? Extracellular edema is either in the interstitium here, or it is in serous body cavities. Serous body cavities are, yes, pericardium. When there is excessive fluid in pericardium, we call it? Just a minute. When there is excessive fluid in the pericardium, we call it? We call it pericardial effusion. Okay, we can call it pericardial effusion, very good. Or we can call it hydropericardium, very good, hydropericardium. When there is excessive fluid in the pericardium, what we call it? Hydropericardium, or we call it, as you said, pericardial effusion. Someone said pericardial tamponade. Someone said it. Who was that? Raise your hand. Raise your both hands. You are absolutely wrong. What is cardiac tamponade? It means you don't have the concept of cardiac tamponade. Listen, let me tell you. If there is normal fluid here, then we say this is normal pericardial fluid, of course. But when there is excessive fluid, we call there is pericardial effusion. And now listen carefully. And if due to excessive fluid, if due to accumulation of excessive fluid, cardiac filling is significantly compromised, then that is called cardiac tamponade. You understand it? Whenever you have extra fluid here in the pericardium, that is not cardiac tamponade. Having more fluid here is just pericardial effusion. But when effusion is able to compress the heart and does not allow the heart during diastole to fill and compromises cardiac function, then we say there is cardiac tamponade. So please, yes. Now in acute case, if there is cardiac pericardial effusion, if it rapidly develops, a small effusion can produce tamponade. But if pericardial effusion is developing very gradually, very slowly over the months and years, then too much fluid can accumulate in pericardium and still it doesn't compress heart. So we say there is big pericardial effusion, but there is no cardiac tamponade. Am I clear?
Yes.
So next time in your life, before you speak about tamponade, remember, tamponade is only there when effusion is able to compromise cardiac function. Right? Now let's move forward. So hydropericardium. What else? Pleural cavity may have extra Fluid. Normally there is fluid. If pleural cavity has extra fluid, we can call it pleural effusion. We can also call it hydrothorax. In the same way, if there is excess fluid in the peritoneal cavity, we can call it peritoneal effusion, which is less commonly used term. More commonly, we can say hydroperitoneum, but very commonly we use the word very good, ascites, excellent. Who said ascites first? Very good. So when ascites becomes symptomatic, how large an ascitic fluid should be to detect it clinically? Just a minute. First, let me clear my question. When there is normally peritoneal cavity in abdomen does have a little fluid, okay? If there is excessive fluid there, we call it hydroperitoneum or we call it ascites. Very good. My question is that if a person is having ascites, it starts developing. Maybe in the very beginning, a slight increase in fluid cannot be detected clinically. How much fluid, extra fluid, or how much total amount of fluid should be present in my peritoneal cavity to be detected by a astute clinician, a sharp doctor? Yes. No, you are not understanding my question. 2.5 liter, absolutely wrong. If some doctor can guess that I have developed 2.5 liter of water and only then he can guess, he is a very pathetic clinical method. That is, listen, if you are able to detect the ascites when I have developed 2.5 liter of fluid in my abdomen, that is not a great physician. A very sharp physician should have so good clinical methods that he should be able to detect even a small amount of fluid in the abdomen, free fluid. How small can be usually detected by a good doctor? I'm not talking about doctor with, yes.
0.5 liter.
Yes, half liter. A good doctor should be able to detect presence of ascites when it is about half liter. And if someone only detect ascites when there is 2.5 liter water, oh, that is a very sad and bad situation for that doctor. Okay? And for patient too. Anyway, so we were talking about extracellular edema, mean edema fluid, excessive fluid in interstitial area and or serous body cavities. I'm saying serous body cavities, not every body cavity. I have a nasal cavity. It doesn't have edema there. I just get nasal secretions. There are other cavities, I will not comment there. Right? So what I'm talking about, serous body cavities, especially pericardial cavity, peritoneal cavity, and pleural cavity, right? So this is a basic concept of edema, right? But here I would love to mention one more thing, that as we mentioned, if fluid is more here, intracellular edema, fluid is more here, excessive fluid here and here, extracellular edema. But if there is excessive fluid here, what is that? If we take a tissue, let's suppose you take a small tissue here, and there is excessive amount of blood present in microcirculation. Excessive amount of blood or fluid present in microcirculation. Of course we know, we don't call it edema. We don't call it edema. What do we call it? Yes, anyone? Raise your hand. All of you know it, but you don't know you know it. Yes. Hypervolemia is a simple term. Yes. You can call it simply hypervolemia, but hypervolemia is usually used when all body has total blood volume more than normal. But I'm talking about a specific tissue. If there's a small amount of tissue, right, and due to some reason in this tissue, amount of blood in microcirculation is more than normal, right? Okay, talk about my finger. In my finger, due to some reason, total amount of blood is more than the normal. Don't call it edema, because edema will be called if there is excessive fluid either intracellularly in the finger or excessive fluid in the interstitium of the finger. Then it is edema. But if there is excessive fluid in the vascular compartment of the finger, we will call it, very good, we'll call it hyperemia or congestion. We'll call it We can call it hyperemia or congestion. Now a good doctor will tell me what is the difference in hyperemia. Listen, if I have excessive amount of fluid or blood in my circulatory compartment of this finger, one finger, or some small tissue, we say either tissue is hyperemic or tissue is having circulation which is congested. What is the real difference between hyperemia and congestion? She is very shy. She doesn't want to reveal her knowledge. Yes?
Hyperemia is increased blood to that area and congestion is blockage.
Excellent. Very good. I told she is shy, otherwise she knows. Hyperemia is that excessive amount of blood is because more blood is entering here. Because more blood is entering here. Is that right? If there is arteriolar dilation here, an excessive amount of blood is entering here and total amount of blood here is more because of more arrival of blood into tissue, we say tissue is hyperemic. And tissue look a little reddish. We call it, there is erythema. What we call it? There is erythema. Classically this is seen in inflammation. But why to go for inflammation? Do a little exercise and tissue has more blood. But don't tell that my tissue develop edema. You say that there is increased blood flow in the tissue and we can call what is there? Hyperemia. Right? But if there is, due to some reason, blood flow out of the tissue is reduced, if there is some obstruction to the outflow or due to any reason, outflow, for example, if there is a thrombus here and outflow of the blood is reduced, then excessive fluid is accumulated here. This situation is called congestion. So again, if there is excessive fluid present in intracellular compartment, intracellular edema, if there is excessive fluid in interstitium and body cavities, this is called extracellular edema. But generally speaking, in medical literature and generally in discussions, medical community call edema, if not specified, only for extracellular edema. But please don't say that excess fluid in body tissues is edema, because blood is also body tissue, right? But if there's excessive fluid here, it is either hyperemia when there is more inflow of the blood, or it is congestion if there is decreased outflow of the blood. Any question up to this?
So what is vascular engorgement?
Oh my God, you are thinking of engorged things. He's asking what is vascular engorgement, right? So many things coming in my mind, but I will stay simple. Engorgement is that when blood vessels dilate and more blood come into tissue and venous outflow from a particular organ is reduced. Just imagine an organ, it's up to your wild imagination, and more blood is coming in due to arteriolar dilatation and less blood is going out due to venous compression. We say there is an engorgement of the tissue. Is that right? And in this case, hyperemia is there as well as congestion is there. We can use the word engorgement. A very dangerous word, am I right? So anyway, let's come back to edema. Any question up to this? Yes?
We can see in this details that hyperemia can occur only in arteries and congestion occur only in veins.
No. He is saying that hyperemia can occur only in arteries. No, I'm talking about this accumulation of fluid is in the microcirculation, which may be arteriole and capillaries or metacapillaries or whatever types of capillaries and venules and veins. Excessive blood here is simply excessive blood. Thank God doctor didn't put any name, or maybe he is trying to put a name here that we say microcirculation is engorged. If microcirculation here is engorged, then this engorgement is due to excessive fluid input, then it will be engorgement and hyperemia, right? But if engorgement is due to decreased fluid going out, excessive blood here, then we say there is congestion, right? Classically, when we say a specific tissue is engorged, there is arteriolar dilatation, so hyperemia is occurring, and venous compression, so there is degree of congestion there too, right? So engorgement, both components can be there, right? But let's go back to edema. Okay, before I really go into very big detail of extracellular edema, right, I will mention few words about intracellular edema, which is also called cellular swelling. right? So a few words about intracellular edema, and then we go into detail of extracellular edema, which is called just edema also. Cellular edema. Now, when we talk about intracellular edema, it means there is excessive fluid in the intracellular compartment. It means cells are swollen. Is that right? In what condition it can happen? Why excessive fluid will enter into cells? What could be the reason? Anyone from the last row? No, from the last row. Anyone?
Hyperosmolarity, sir.
Okay, you are saying hyperosmolarity. Where? Extracellularly or intracellular? Intracellularly. Very good. That inside the cell, if inside the cell is hyperosmolar, if there is more solute in the cells, actually let me tell you, he is right. If whenever there is more solute in the cells or the less solutes outside the cells, water will shift to the intracellular compartment. Right? Now, what could be the reasons of why the cells become hyperosmolar? Okay, you are saying that intracellular edema may be due to increased osmolarity of intracellular fluid.
Yes.
Why this fluid become hyperosmolar? Raise your hand. Just to remind, everyone has two hands. Yes.
Sir, sodium and potassium ions movement differs the osmolarity, normal osmolarity up to 82 milliosmol per liter.
Okay, he is trying to impress me. He has read something which he doesn't remember clearly, but he has read something. Let me explain what he is trying to say. All of you know that every cell has special type of pump which is called sodium potassium ATPase, sodium potassium pump. Sodium potassium pump is all the time taking 3 ions of sodium outside and always actively pushing 2 ions of potassium inside. It is taking 2 potassium in and it is taking 3 sodiums out. Is that right? This is sodium potassium pump, which is always pumping the sodium out of the cells and taking the potassium in. Is that right? Now, due to some reason, if this pump is not working well, then it is not bringing 2 potassium in, but it is keeping the 3 sodium in, and gradually sodium will accumulate in the cell, and then cell will become hyperosmotic and pull the extracellular water in. So whenever sodium potassium pumps, which are present in every cell, more accurately they should be called sodium potassium ATPases. What we call sodium potassium ATPases, because this pump has special enzyme which break down the ATP, uses the energy of ATP to operate and do its function, right? We call it sodium potassium ATPases. If due to any reason sodium potassium ATPases are not working, then sodium is no more expelled from the cells. The sodium which is retained in the cell, that pulls the water with it, and cell become swollen and intracellular edema develop. But can you tell me a condition in which sodium potassium ATPases will not be working, any pathological disease condition? Yes, Azaz. Conditions in which sodium potassium ATPases are not working, he is right, but he should explain more elaborately. Simple as that, I mentioned. So just a minute now, my turn. Sodium potassium ATPase is using ATP. ATP is the energy in the cell. If cells become hypoxic, it's very simple. If any tissue become ischemic, there's less blood flow going there, less oxygen going there, less glucose and other nutrients going there. If the tissue is ischemic or cell is ischemic, can cell make without oxygen, without glucose or other nutrients, can it make ATP? No. If it cannot make energy, how it will operate the pump? And if this pump is not working, how it will throw the sodium out? Sodium love to go in. It is like, I must say, I will not say what kind of ion, what kind of behavior, but it loves to go in, right? So we have to push it out all the time out of the cell. Why you are smiling? Very naughty smile on your face. All boys, very bad. Okay, sodium is just sodium ion, okay? So it loves to go in and we keep on pushing it out. But whenever the tissue is ischemic or hypoxic, less oxygen, energy producing pathways collapse, ATP deficiency develops, sodium potassium ATPases are not working, sodium start accumulating in the cells and sodium will pull the water with it and cell will swollen up. Is that right? These are like unhappy cells, like making unhappy face. Is that clear? So these are swollen cells, no energy. If you don't have money, how is your face? A big one. In the same way, when cells don't have ATP, no energy, they also make a big face, right? So hypoxia, ischemia can make the cells edematous, swollen. This is one of the features of cell injury. Then, due to any other toxin, if mitochondria are damaged, still ATP is not produced because ATP is mainly produced through the help of mitochondria. And if mitochondrial machinery fails, ATP is not produced, sodium potassium ATPases are not working, again cells will undergo swelling, right? Then any type of injury direct to the membrane. Remember, outside the cells, there's a lot of, let me make a cell here, a typical cells are normally, cells have more potassium or sodium? Think and then answer. Yes. Yes, normally my cells have more sodium or more potassium?
Cells are bags of potassium.
Wow, that's very good. Cells are just bags of potassium. They have a lot of potassium. That is why when crush injury is there, when there is crush injury, a lot of cells rupture and potassium come out in the blood and hyperkalemia develops. Right, but anyway, come back. Cells are the bags of potassium. And cells love to keep the sodium outside. Cells love to keep the sodium outside, extracellularly. Sodium binds a lot of water with it. So sodium cannot enter into cells through the simple cell membranes. Sodium can only enter into cells through special transport mechanisms or channels, right? But whatever sodium enter into cell, we must get it out. We must get it out. Now, so outside, there is high concentration of sodium and inside there is high concentration of potassium. And also there is one more ion which is extracellularly in high concentration outside as compared to the inside. Very important. Okay, chloride, but more important than chloride. Calcium. It's very important. So extracellular environment is rich in sodium and calcium and many other things, of course. But right now it's relevant that extracellular environment is rich in sodium and calcium. Intracellular environment is rich in potassium and other things. Now, if normally cell membrane is not freely permeable to these sodium and calcium. Normally cell membranes are not freely permeable to sodium and calcium. So normally sodium are trying to go in, but they are repelled. In the same way, calcium loves to go in, but it is not allowed. Only under special physiological functions, sodium and calcium go in. Like sodium goes in during action potentials, depolarization, or calcium go in when there is some secretory functions. But remember, normally extracellular fluid is rich in sodium and calcium, intracellular fluid is rich in potassium. And if there is membrane damage, due to any reason, whatever the reason, if cell membranes are damaged in any way, what will go in? Sodium and calcium. And the sodium and calcium, when it will go in, not only in toxic concentration, it will hurt the intracellular machinery, but it will do one more thing. It will drag the water with it and cell will start swelling. So intracellular edema, it may be due to impairment of sodium potassium ATPases, which fail to keep the sodium out and sodium start being retained inside, or intracellular edema may occur when generally cell membranes are damaged, whatever the mechanism, whatever the cause, whatever etiology, right? Then one more condition. Let's suppose in this cell, sodium potassium ATPases are working fine, sodium potassium ATPs are working fine, and generally cell membrane is also okay. Cell membrane is also okay, right? In this cell, but due to some reason, outside the cell, hyponatremia develops. What is the difference of sodium concentration in the blood in the plasma and interstitial fluid? Some very good doctor can answer, everyone cannot. My question is, what is the sodium concentration difference between the blood concentration of sodium and interstitial concentration of sodium? Here I have told you, intracellular fluid, very poor in sodium, extracellular fluid, very rich in sodium. But now I'm asking a tricky question, that sodium concentration difference in blood and interstitial fluid. Yes, ma'am.
Interstitial sodium is excessive?
In normal person, healthy person, you think interstitial fluid is more? Yes, ma'am. You also agree with her. But remember, medical facts are not decided by democracy. The 10 people are wrong, then right become wrong. Yes, ma'am. G. Same. Why you think it should be the same in the vascular compartment and here? Because capillaries are freely permeable to sodium. He is right. Oh my God. You don't know this. Sodium chloride and many ions concentration in the plasma and interstitial fluid is same. Because sodium is freely permeable here. Here it cannot freely go. Sodium is like men. It can be on the road or it can be on the side of the road. But men are not allowed to enter in every house. You understand? And you know why? And if they enter in under special circumstances, sodium channel open like windows when someone call at midnight, or maybe daytime when doorbell and special channel sodium goes in, right? But if sodium goes inappropriately, who throws it out? Sodium potassium ATPase. It comes, it is kicked out. Is that right? But sodium concentration in the cell, in extracellular fluid, everywhere is same. In the blood and interstitial fluid is same. You are understanding? Am I clear?
Yes.
Okay. But here, now I was saying, due to any reason, if you develop hyponatremia means in the blood sodium level is less. Natremia, when it is emia, it means it's pertaining to blood. So when I say the person has hyponatremia, what does it mean? Sodium concentration in the blood is less. What is the normal concentration of sodium in the blood? Yes, only this man. Yeah, he is smiling but not telling. Normal concentration of sodium in the blood. Oh no, I know you know the ions too much. You are in love of electrolytes, electrophilic boy.
142.
142 what? Machine guns? Milli equivalent per liter. Okay, all of you are right that when we say normal amount of sodium in the blood is 142 milli equivalent per liter, but please be a good doctor, tell me the range. Don't tell me 142. The way you are telling me that normal sodium is 142, it means if I have 41 or 43, it is abnormal. It is not abnormal. So what is the range?
135 to 145.
Oh my God, I don't know, you are very consistent to be wrong today. Sodium is 135 to 145 milli equivalent, yes? Milli equivalents per liter or millimole per liter. So why it's so important to know that lower limit is 135, upper limit is 145? Because when sodium becomes less than 135, we say that patient is going to hyponatremia. Because hyponatremia is basically defined as amount of sodium, a concentration of sodium in the blood less than 135 milli equivalent per liter or millimole per liter, right? Even though clinical problems start appearing at lower level of sodium. But what I'm saying, whatever sodium level is here, the same level is here. Let's suppose someone has severe hyponatremia, rapidly developing severe hyponatremia. Sodium level drop very rapidly in the blood. Of course, they will also drop here. And sodium become less. Sodium love to hold water. If sodium is very less here, inside the cell, normally, the cations and anion, total osmolarity inside the cell and outside the cell, normally it is equal or different? Equal. Normally it is equal. So what happens, even though there are different type of ions here and there are other different type of ions here, but in total, extracellular osmolarity and intracellular osmolarity in physiological condition is, in most of the tissue, is equal. But if from outside we remove the sodium, so it becomes hyponatremic situation, right? And it becomes hyposmolar, low osmolarity. what will happen to the cells? They will absorb water because cells will be hyperosmolar as compared to interstitium and blood. Again, I will repeat it. If I develop rapidly hyponatremia, whatever the mechanism, if my sodium level in the blood is going down, of course it will also go down in interstitium. Interstitial fluid is surrounding all the cells. So all the cells have around them less than normal sodium. So around the cell there is hypoosmolarity, and when there is hypoosmolarity, of course then normosmolarity of the cell will be more than the surrounding fluid, and it will pull the water in and cells will again swell. So cellular edema. Cellular edema can be due to three mechanisms I told you. Number one, I just told you now, cellular edema can be due to low sodium, hyponatremia, or cellular swelling may be due to cell membrane damage. Cell membrane damage. When cell membrane is damaged, right, sodium and calcium will jump in and water will follow. And then I told you those conditions in which sodium potassium ATPases are impaired, where sodium potassium ATPases are impaired. It may be hypoxia or ischemia or whatever, right? So these are the conditions in which there can be intracellular edema. Now we forget about the intracellular edema. Now we come to the real edema, which most of the doctors talk about, that is extracellular edema. Because when in your wards or generally when you speak with each other, you say patient has edema, usually it is meant extracellular edema. Because if patient has intracellular edema, we always mention there is intracellular edema, right? So now our lecture will go towards what are the causes and mechanism of extracellular edema, why excessive fluid accumulate in interstitium and or body cavities. Let's have a break and then we'll continue with this discussion. Right. In previous lecture we were talking about edema, right? And we defined edema as, how the edema was defined? Yes, please.
Excessive fluid in the interstitial.
Edema was defined as excessive fluid in body tissues. Excessive fluid in the body tissue. And then we divided edema in two types of edema, intracellular edema and extracellular edema. And we discussed intracellular edema is in excessive fluid inside the cells where cells are swollen, especially after ATPase pump failure or hypoxia, ischemia, cell membrane injury, right? And then we were talking about extracellular edema. And there we discussed extracellular edema is actually excessive amount of fluid present in interstitium and or body serous cavities, right? Now today we'll go into detail of the specially extracellular edema. We'll talk about extracellular edema. Now onward in this series of lectures, when I use the word edema, you should pre-assume that I'm talking about extracellular edema, right? So let's go for that. Let's suppose here is your arterial system. Here was your left heart, right? And you know left heart is pumping in the body. It's left heart, not anything else, right? With the aorta. And let's suppose here is an arterial system coming out. This is representing, let me make a piece of tissue here. Let's suppose this is a piece of tissue. And this is the arterial input into this tissue, right? You know arteries divide into arterioles and then metarterioles and eventually into capillary network. And here is the venous output from that specific tissue which we have put it over here. And here is your micro circulation. I'm going to make microcirculation here in between the arterial end and the venous end. Okay. So in this specific tissue, this is arterial end of the microcirculation and here is the venous end of the microcirculation, and here is your microcirculation, and let's suppose here are your parenchymal cells, right? These are parenchymal cells, and these are, of course, what are these cells? Endothelial cells, right? Along with the basement membrane and the capillaries and venules. And the blood which is draining from the tissues eventually go into major veins, which will eventually drain into right heart, right? They will drain into right heart, which will itself eventually drain into lungs, right? And now this is pulmonary, yes, tell me. Pulmonary artery, and here is the pulmonary veins, and in between them there is pulmonary microcirculation, right? It shouldn't go out of the lung. Now, as we were discussing yesterday, that when we talk about interstitial edema, this is the area which is, interstitium is basically area which is outside the circulation and also outside the parenchymal functional cells, right? When we say that there is interstitial edema, it means edema is in this area, right? And as we define that there is excessive fluid in the interstitium when there is edema, but normally there is some fluid in the interstitium. In a man with 72 kg weight, usually how much interstitial fluid is there? Yesterday we discussed that is around 10 to 11 liters, right? But if interstitial fluid become excessive in all over the body or in a localized area, we say there is edema. Now, what is the function of interstitial edema? Or sorry, what is the function of the interstitium? And what is the relationship of interstitial fluid with the plasma fluid or blood fluid? That is first thing to understand. Because let's suppose we say that there should be 10 liter fluid present in this area. But do you think this fluid is static or dynamic? Is it always there or it keep on changing? Yes, ma'am. It's keep on changing. What normally happen that all the time, okay, I'm dividing this into microcirculation and venous side of the microcirculation. Now, what normally happens all over your body, from arterial side of the microcirculation, fluid is coming out constantly. Fluid is coming out, and this fluid is bringing the oxygen and bringing glucose and other nutrients. And this fluid is serving these cells. That's why they are so happy. Oxygen is coming, glucose is coming, amino acids are coming, and many other things. And then this fluid goes back from this area, right? It's coming, serving these cells, right? Washing these cells, providing them the nutrients and removing their waste product. And then this fluid, let's suppose, comes here and then goes back, right? All your capillaries, in all your tissues, a small amount of fluid is coming out, serving the cells and removing the waste product and going back. This is what is normal mechanism, right? Plus, usually a very small amount of protein leak out, not much. A very small amount of protein also leak out, which cannot be pulled back here. That small amount of protein, along with some small amount of fluid, is drained by another pathway, and that is called lymphatics. It means that most of the fluid, about 80 to 90% fluid, which comes out from arterial side of microcirculation, adds to interstitium and constantly being sucked back into venous end of the microcirculation, and about 10 to 15% fluid along with proteins. These are proteins. It is being drained into lymphatics. It is being drained into lymphatics. But remember, all lymph fluid eventually drains back into, yes, venous system. You know, all the lymph of the body eventually drain through the thoracic duct system into subclavian and internal jugular venous system. So in a way, we can say that in a typical tissue, the fluid input is by arterial side and fluid output is mainly by the venous side, and also there is an accessory pathway, an additional pathway for fluid draining through the lymphatics. But both of these eventually go back to the venous system. Is that clear? Now how the edema will fall? How the edema can be made? How this fluid suddenly become too much? It's very easy to understand. I don't know why they teach in medical sciences. It's so easy. It's very simple. Either too much fluid is coming from here. If more than normal fluid is, too much fluid come here, and then edema will occur. Or this refused to take the fluid back. It is not sucking the fluid back. Again fluid will accumulate. Or lymphatic system is not working, again fluid will accumulate. These are three basic mechanisms. Even though for edema there are more mechanisms too. But let me tell you three basic mechanisms. Well, rather four basic mechanisms. First of all, when fluid is trying to come out, it has to pass through, what is this? Capillary membrane, which is semi-permeable membrane. If fluid has to come out, it has to pass through capillary membrane. Now, how much fluid will be coming here? How much fluid will be coming here? It depends on multiple factors, including the capillary membrane features. If capillary membrane is damaged, too much fluid will come. If this membrane is damaged from inside, too much fluid will come. So we can say that in a general concept, why edema should be there, interstitial edema? Very simple. Either more fluid is coming to this tissue, or less fluid is draining on the venous end of the microcirculation, or less fluid is draining into lymphatics. That's so simple. Or there is increased permeability of microcirculation, right? So how many things I mentioned? Either more fluid coming out through microcirculation, number one mechanism. Number two, or there is decreased reabsorption of fluid, number two mechanism. Number three, or there is decreased lymphatic drainage, number three mechanism. Or overall in the body, salt and water is too much. I will explain the mechanism later. If body retains excessive salt and water, not only excessive fluid will be here, it will also come here. So that will also add to the edema. And eventually, if permeability of this membrane is increased pathologically, then excessive fluid will also leak out. Any question up to this? Everyone is clear? So now, first of all, I will talk about why in some disease condition, fluid is excessively coming out. But before really we go into that condition, we will talk about normal physiological mechanisms. I will tell you how in a normal healthy person, in a healthy tissue, how this fluid movement out and back is regulated. What are the factors which push the fluid out, and what are the factors which reabsorb the fluid? Because when those factors are disturbed, edema will occur. You are understanding? Now what are the factors normally? First of all, when heart is pumping left ventricle, it is pushing the blood into whole body circulation with pressure. The pressure which is generated by pumping of the heart, that pressure is called hydrostatic pressure. Normally you call it blood pressure, right? And of course, as blood is moving forward and it divides into different arterial tree and arterioles and smaller, hydrostatic pressure will keep on dropping. Is that right? From here the blood is pumped with pressure. Heart is pumping the blood in the tissues with pressure. But as it is moving forward, pressure will drop. Is that right? But in a typical tissue, in a classical tissue, for example, we are taking this example, the hydrostatic pressure is, let's suppose, 35 millimeter of mercury. So I will just write it here. This is hydrostatic pressure. What is this? In a normal tissue, this hypothetical tissue which I am showing here, it has pressure of 35 millimeter of mercury. Now if fluid is under pressure here and heart is pushing under pressure, it will love to go out. It will love to go out. So it means outward pressures is how much? 35 millimeter of mercury. It is trying to push the fluid on both directions outside. Am I clear? But there is something which holds the fluid in. Normally, hydrostatic pressure is trying to push the fluid outward, but there is something which is not pusher. You can say hydrostatic pressure in the vascular system, right? Hydrostatic pressure is little here, but hydrostatic pressure here and osmotic pressure here I will ignore in this discussion because there are minor factors. Major factor here which I am mentioning, hydrostatic pressure inside the microcirculation on the arterial side of the vessels. Now it is 35 millimeter of mercury, and with this 35 millimeter of mercury it is trying to push the fluid outward, but there is something which is not pusher. This pressure we can say is pusher. It is pushing the fluid outward. Whenever there is a pusher, there must be a sucker or at least holder. Why you laugh at sucker? I'm not talking about that sucker which is coming to your mind. Sucker means suck the fluid back. Okay? So what we are talking about, there is a hold. Okay, I will not use the word holder, sucker. I will use the word holder. Plasma proteins. You know, plasma proteins, in this plasma, there are certain proteins which are globulins and albumins and fibrinogen, but classically albumin. That plasma protein has a power to retain the fluid. Plasma protein has the power to hold the fluid. They hold the water. Hydrostatic pressure is trying to get the water out, and osmotic pressure which is exerted by the presence of plasma protein, especially albumin, that is trying to hold the water within circulatory compartment. And osmotic pressure which is determined by the plasma protein, that is usually 25 millimeter of mercury. That is trying to hold the fluid. And what it is doing? It is trying to keep the water inward. It is trying to keep the water inward. Now we can see that hydrodynamic forces which will eventually determine the movement of the fluid here is determined by the balance between these two forces. This is acting as a pusher and this is acting as a holder or sucker. So power outward is 35, power inward is 25. So fluid will move outward or inward? Outward. So net pressure, the difference is net outward pressure is 35 minus 25. So this is the pressure with which fluid will be coming out, right? And this is 10 millimeter of mercury. So we can say in a normal tissue, on arterial end of the microcirculation, with the net filter out pressure, what we can say? Filtration pressure. What is this? Filtration pressure. Forces out the fluid along with its dissolved components through the semi-permeable membrane from the intravascular compartment to the interstitial compartment with the net filtration pressure of 10 millimeter of mercury. I will repeat it. That usually tissues to tissues, these values little vary. We are taking a typical tissue. In a typical tissue on the arterial side of the microcirculation, hydrostatic pressure is about 35 millimeter of mercury and colloid osmotic pressure is 25 millimeter of mercury. Okay, we call colloid osmotic pressure, or some books write oncotic pressure. What is the difference in colloid osmotic pressure and oncotic pressure? Yes, please.
Same.
They are the same.
One is due to albumin.
Okay, just a minute. Colloid osmotic pressure, right? This is one term, versus oncotic pressure. Oncotic pressure. What is the difference in them? Before you tell me any difference, there is no difference. They are one and the same thing. Colloid osmotic pressure, which is determined by the plasma proteins, that is also called just oncotic pressure. But if there is colloidal osmotic pressure due to proteins in the interstitial tissue, that is not called oncotic pressure. Actually, when colloidal molecules like plasma proteins, because when fluid is going out, plasma proteins cannot go out. So what plasma proteins will do? Try to hold the water. For example, if husband is going to the other country, if wife cannot go, she will try to hold the husband, don't go. That is an example of colloidal osmotic pressure. But maybe financial pressures are there, he has to go. Do you get it? Now what I'm trying to say, that colloid osmotic pressure simply means that osmotic pressure determined by the colloidal molecules. But when we use the term oncotic pressure, it means colloid osmotic pressure produced due to plasma proteins. Interstitial proteins also exert some colloid osmotic pressure, but that is not called oncotic pressure. Am I clear? Yes. So now onwards in our discussion, I may use the term colloid osmotic pressure, or may use the term only osmotic pressure, or I may use the term oncotic pressure. So it's one and the same thing in our discussion forward. So we decided that on this side, fluid will gradually come out slowly and it will come to the tissue survey. But what really happens? As some fluid is lost, but intravascular fluid is moving to the venous end, it is moving forward, hydrostatic pressure will drop. Why it will drop? Because microcirculation, as it moves from arterial end to the venous end, it becomes wide bore diameter. Its total cross-sectional area increases, right? So naturally pressures will drop. If there is some pipe, if suddenly you expand it, pressure inside will decrease. So here pressure decreases, and on this side, this on hydrostatic pressure usually become only 15 millimeter of mercury. But plasma protein osmotic pressure or oncotic pressure remains almost same, because proteins did not leak out. The amount of protein which was here and amount of protein which is here is almost same. So osmotic pressure remain the same. Is that right? But hydrostatic pressure, here it was 35 and here it is 15. So it means now hydrodynamic mechanisms shift. A little point. Actually, when some amount of fluid seep out, filter out, plasma protein become a little concentrated. And when plasma proteins become little concentrated, oncotic pressure become little more. Rather than 25, it may become 27 or 28. But for our discussion, we will not go into that detail. We just assume as fluid is moving in microcirculation, on the arterial end it is losing the fluid. Is that right? Cells, especially red blood cells and what platelets, they are not coming out. Only leukocytes under certain circumstances they come out, and plasma proteins are not mainly going out. Most of the plasma proteins are retained here. Very little plasma proteins leak out, which will be taken back through lymphatic system. Is that clear? Now look at the balance, hydrodynamic forces balance here. These forces are also called Starling forces, right? What is the balance here? Now 25 is the puller. 25 is the puller, or we can say sucker. It is trying to suck the fluid, and pusher is very weak. It is only 15. So what will be the net effect? It will pull the fluid from here backward. Because net difference, 25 is pulling in, 15 is just like 25 men pulling a person inward and 15 pushing it outward. Still this men will move inward. So fluids slowly start going back, right? And net filtration pressure is now inward. Here net filtration pressure was outward. So under the 10 millimeter of mercury diff, right, fluid was filtering out on arterial side of microcirculation, and here at almost 10 millimeter of mercury, fluid was being sucked back or reabsorbed back, right? But a small amount of protein which was leaking from here, a very small amount of protein which leaked from here, it cannot be sucked back. They are larger molecules and some cellular debris or even microbe. So they will be drained through this pathway. This is our secret pathway. Lymphatics is an additional or secret pathway to drain the protein-rich fluid. Is that clear? This is very important, that don't allow these small amount of proteins which are leaking here to stay here. It should not stay here. It should be taken back, because if these proteins keep on coming here and they are not drained, they accumulate here, those proteins will increase the osmotic pressure here and they will start holding the water and produce edema. Now these are the normal basic mechanisms, right? So what are the factors which determine the amount of fluid in interstitial tissue, interstitial area? Number one, hydrostatic pressure. It determines how much fluid will go out on this side. Osmotic pressure or oncotic pressure, which determines how it will be pulled back. And then lymphatic drainage. Is that another way to look at it? That this side of circulatory system, we can say for fluid, intravascular fluid, it is pusher. And this side of the circulation act as a reabsorbing mechanism or suckers. Here is the pusher and here is the sucker, right? In every tissue you have a pusher and you have a sucker. I hope you will remember that. There is a pushing mechanism and there is a suction mechanism, not sucking mechanism, right? Now, let's suppose we disturb these mechanisms. Let's suppose we disturb these mechanisms and see how edema occurs. I will go in detail later, but just I will mention the mechanisms. Let's suppose due to any reason, hydrostatic pressure increases here. Due to any reason, hydrostatic pressure increases here. If there is increased hydrostatic pressure in the microcirculation, what will happen? Just imagine, due to, in one person, there is severe arterial dilation. Arteries dilate and too much fluid enter here. This pressure will be 35 or it will go up? It will go up. Or it is normal, but this venous outflow is reduced due to any mechanism which we close this, or due to any reason blood cannot go back to venous system easily, right? If for example there is a thrombus here, if blood cannot go out easily and some of it is not going out, what will happen to hydrostatic pressures here? Increase. So if due to any reason, if there is increased hydrostatic pressure in microcirculation, let's see what happens. Let's suppose hydrostatic pressure has addition of 20 millimeter of mercury here, and of course 20 millimeter of mercury here. Now rather than 35, how much is it? 55. Okay, don't do that much. Let's put it only 10. We increase the pressure of 10 here and we increase the pressure of 10 here. Now it is how much? 45, and it is still 25. So pressure outward, filtration out, pressure will decrease or increase? It will become double and it will become 20 millimeter of mercury. When hydrostatic pressure increases here, either due to arteriolar dilatation or due to venous increased resistance to the venous outflow. When hydrostatic pressure increases here, right, the result will be, yes, filtration out will be more. And on this side, look at it. If this is also, rather than 15, 10 is added, 25. Now osmotic is 25 and it is also 25. Do you think it can act as a sucker? Can it suck? No. So what will happen? Excessive amount of fluid is coming into interstitium but venous side is unable to reabsorb the fluid properly. So too much fluid is coming out but not going back. So there is excessive fluid arriving here. Is that right? If excessive fluid is arriving here, what will happen then? Yes. Before the edema develops, let me tell you something very important. Lymphatics. They increase their capacity to drain. Lymphatics can increase their capacity to drain the fluid. So as pressure keep on increasing here, filtration pressure, net filtration out pressure increases, net filtration out fluid increases, reabsorption fluid decreases. Whatever extra fluid is coming, it will not produce edema immediately. First, initial fluid that will be drained through this. It will increase its power to drain. But it has a limitation. When fluid coming out becomes so much that lymphatics are overwhelmed, when fluid coming out due to increased hydrostatic pressure becomes so much that lymphatic, in spite of increasing their draining capacity, they still cannot drain all additional fluid. If they cannot drain all additional fluid, then fluid start accumulating here and edema develops. And what develops? Interstitial edema develops. So first mechanism of interstitial edema, I told you that when there is increased hydrostatic pressure, increased hydrostatic pressure. Now the second mechanism of edema. I will go into detail later what are the diseases and conditions in which hydrostatic pressure goes up. But right now just basics. Now we imagine another person. Let's suppose hydrostatic pressure is normal. How much it should be here? 35, yes, normal. And if it is normal, how much it should be? 15 millimeter of mercury. Let's suppose due to some reason, those reasons we'll talk later, due to some reason, concentration of plasma proteins drop. What is the normal, what is the normal concentration of plasma proteins? Anyone from this row? Yes. Yes, please. What is the normal concentration of plasma proteins? Yes. 8.5 what? Tanks? Tanks or what?
Millimole per
We can mention plasma protein levels in two ways. Total plasma proteins. You can say it is 6.0 to 8.0 grams per deciliter. Or we can say 6 to 8 grams per 100 ml. Deciliter is 100 ml. Or we can say 60 to 80 grams per liter. You are understanding? Because 10 deciliter is equal to 1 liter. So in some books, because I don't want you to be confused, some books mention it is 6 to 8 grams per deciliter, or other books mention 60 to 80 grams per liter. But it's one and the same thing. Total plasma protein. But out of total plasma protein, as you know that there are three types, there are many types of plasma proteins, but three are very important. Number one, albumin. Number two, very good, globulin. Number three, fibrinogen. Right? And there are many others, but I will not go into detail. Albumin normal level are how much? Yes, albumin 3.3 to 5.5 or maximum 5 grams per dl or per 100 ml. Globulins are 1.5 to 2.5 grams per dl. Fibrinogen is 0.25 to 0.5 grams per dl. But right now what I want to tell you, out of these proteins, if you take the total proteins present here, right, they are usually 6 to 8 grams per 100 ml of the plasma, right? It's clear? Out of this, most abundant protein is albumin. It's the maximum. Less than albumin there is globulin, and less than globulin there is fibrinogen. Now, because albumin is most abundant in the blood and number of molecules of albumin are smaller, so albumin is the main protein which determines the osmotic pressure. So who is the main sucker or holder of the water? I must use holder of the water, albumin. Even though holding power of water here is determined mainly by the albumin and to some extent by the other proteins. Now normal healthy person must have 6 to 8 grams proteins in the blood or 60 to 80 grams per liter proteins. Now if someone has, due to any disease condition, in his blood proteins level go down. If someone has a problem, we'll talk later. Either proteins cannot be synthesized or they are lost out of the body excessively. We'll discuss it later, but for a while we just imagine that I'm suffering with a disease in which plasma level of proteins go dangerously down, right? Albumin become very low. If albumin concentration become very low, what do you think? This osmotic pressure will remain same or it will become less? Less. So let's suppose due to low albumin, osmotic pressure become only 15. Now hydrostatic pressure is normal, but osmotic pressure of the proteins have gone down, or on plasma oncotic pressure has gone down due to hypoproteinemia, low protein level, or to be more specifically we can say hypoalbuminemia. So those diseases in which in the blood albumin level goes down, or there's severe hypoalbuminemia or proteinemia, then plasma proteins ability to hold the water in circulatory system is less. Osmotic pressure is less. Then what will happen? Now in this case, even though hydrostatic pressure is 35, but it is not 25, it is 15. So filter out pressure is again double. So in this patient, previously we had a patient in which hydrostatic pressure here was high, but oncotic pressure was normal previously, and still extra fluid was coming and less fluid was absorbing, and extra which was draining through lymphatic, if it couldn't be drained fully, then it will accumulate and produce edema. Now we discuss another condition, that group of patients in which what is happening? The plasma protein levels go down, osmotic pressures of circulatory system become less, then throughout the capillaries in the body, more fluid will leak out and less fluid will reabsorb back. So here on arterial side, it acts as a poor holder. It is not a very good holder. And on venous side of the capillary, it acts as a poor sucker. You are understanding? So what happened under these circumstances? Excessive amount of fluid is leaking out in the interstitium, but can it pull back? No. So what will happen? Edema. What will happen? Edema. Right? Again in this condition also, here edema is due to low oncotic pressures. Right, due to loss of due to low protein levels in the blood. So all those diseases which produce dangerously low proteins in the blood, right, they will result into edema, right, generalized edema. Remember, when edema is all over the body, right, we call it Anasarca. We call it Anasarca. Anasarca. It is generalized edema all over the body, especially in subcutaneous tissue. Anyway, come back. So now we have learned another mechanism. What is that? Second mechanism of production of edema is reduced colloid osmotic pressure or reduced oncotic pressures. Right? This is the second mechanism. So here what we have seen? We have only seen that normally it is the balance of hydrostatic and the osmotic pressures, right? They determine the fluid which is being filtered out and fluid which is being filtered back, reabsorbed, right? If these forces are disturbed, these are called Starling forces. If these forces are dearranged, or we call them hydrodynamic forces. If these hydrodynamic forces balance is disturbed, either hydrostatic pressure is high or osmotic pressure is less than normal, that will result into edema formation. Any question up to this? Then another mechanism of edema, that is very simple. Due to any reason, if blood cannot, lymphatic system cannot drain well. For example, if a female has breast cancer, then breast cancer cells enter into lymph node, and then from the arm, lymph cannot drain well. Lymph cannot drain well. Or due to some radiotherapy, lymphatics are damaged or lymph nodes are damaged, or some infection like filariasis. Filariasis is a nematode, right? This parasite multiplies or stays in the lymphatics. This parasite stays into lymphatics, damages them and produces fibrosis of the lymphatics in the lymph node. So due to any reason, either due to filariasis, due to any infection, lymphatic system is damaged, or due to surgery you remove the lymphatics and lymph node in some area, or due to irradiation lymphatic system is damaged, right? So due to any reason, if lymphatic system is damaged, can fluid go out of the system? Can fluid go out of the system? No. Now, even if these hydrodynamic forces are absolutely normal amount of fluid is filtering out, normal amount of fluid is being reabsorbed, but if this back door is closed, what will happen? Small amount of proteins which are leaking out over the months and years, over the time, they will accumulate here because they are not being drained. So these proteins, when they will accumulate here, they will increase the colloidal osmotic pressure in interstitium, and that will hold the water rate, and this area will swell up, and that will lead to edema. Such kind of edema is called lymphedema. We will have a full lecture on lymphedema later. Here I want to mention one thing. Edema, let's suppose, just imagine, in my right arm, edema developed due to some compression of the vein, right? And on this arm, edema developed because my lymph nodes are blocked due to some pathological process. Is that right? This side will develop edema as well as this. Again, imagine, if this arm has compressed veins, then blood is going through the arterial system, but it cannot go back through veins. So all capillaries in the arm will have high hydrostatic pressure, and fluid will come out, and fluid will accumulate in the arm, and my arm will be edematous. Is that right? This is one situation. Other situation we talk about, that here the lymph nodes due to some disease process are blocked. If these lymph nodes are blocked, blood is going in the arm through the arterial system, draining well through the venous system, but because lymphatics are not draining, small amount of proteins which are left there are not drained, they are not getting back. Those retained proteins will reabsorb, they will hold the water, and this will also get edema. This will also get edema. And these proteins which are leaking out, these proteins which were accumulating here, these proteins, it may have fibrinogen, which will produce semi-clot situation, right? Rather not really clot is really here, I must say coagulation process, right? Or we can say these fibrinogen will try to make fibrin and make a little fibrillar proteins which will hold the water. Plus other proteins which are holding here, those proteins are retaining water held with them. Again, I will repeat. Here only water was there. But were there any proteins here? No. Here there was originally proteins accumulated along with water. Is that right? Now what will be the real difference? Both arms are swollen. Both arms are swollen. But if you press the one point, for example, if this arm is swollen, you press it with thumb firmly, right? And remove the thumb for few seconds, there will be a little depression there. Again, I will repeat. On this side, where fluid was accumulated, but without proteins. When you press with the finger, with pressure, you push the fluid on the side. You push the fluid on the side with pressure. When you remove your thumb, what will happen? That depression point or indentation will be left there, and it will take few seconds, fluid come back, and again that depression is finished. Is that right? We say with finger pressure we can produce a pit here, P-I-T, pit. What we can produce? Pit here. And this type of edema is called pitting edema. What we call it? Pitting edema. But if you come over here and you press it here, now you know that even though there is excessive fluid here and this is edema, but this fluid is held with proteins and maybe some fibrinogen. Maybe those proteins which were accumulated here for a long time, they have activated the fibroblast and some collagen is deposited. So that water which is here, edema water, that is trapped in the proteins and that is held with the proteins. Now if you produce pressure, with pressure you can displace the water, but you cannot displace the proteins. And if you cannot displace the protein, if you put a pressure, you remove your finger, will there be a pit there? No. There will be no depression. This type of edema is called non-pitting edema. So what is the difference in pitting edema and non-pitting edema? Again, listen. Pitting edema is that when you find there is edema, you put a pressure there, you displace the water. There is displaceable water there. Is that right? And when water is displaced, right, you remove your finger, water will take some time to come back, and for short transient time, there will be indentation produced or depression produced, and such kind of edema is pitting edema. Actually, when edema is due to increased hydrostatic pressure or due to reduced osmotic pressure, it is pitting edema. Why? Because if this increases, extra fluid which come here, it is without much proteins. Is that right? Or if this decreases, still extra fluid come but without much protein. So when fluid is held in the tissues but not with excessive proteins and not fibrinogen, right, then this fluid can be displaced and there can be pitting edema. So all those diseases in which hydrostatic pressure is increased or oncotic pressure is decreased, in all those group of diseases, edema which is produced is called pitting edema. But if edema is due to impaired lymphatic drainage, when edema is due to reduced lymphatic drainage, then what is happening? Fluid is retained along with proteins and fibrinogen, and all this will produce such kind of edema, plus proteins which are retained here for long term. Those proteins, some of those proteins stimulate the growth of fibroblasts to produce collagen, right? So what is there? Fibrinogen is there, collagen is there, other extra proteins are there, all of them are holding the water. And when they are holding the water, then if you press this, as you cannot displace the collagen, as you cannot displace the fibrinogen, as you cannot displace with little pressure other proteins, so proteins stay there. When proteins stay there, and trapped water is also staying there, so you cannot produce a pit. So we call this non-pitting edema. Am I clear? Yes. Any question up to this? Here I want to, yes, you have a question.
Yes, sir. So when there is increased amount of blood flow in this microvasculature, there will be accumulation of blood, and there will be the raised hydrostatic pressure. But increased amount of blood in the microvasculature, wouldn't that bring more amount of protein, raising the oncotic pressure also?
Listen, he's saying when there is, let's suppose there is arterial dilation, he's saying when hydrostatic pressure increases here, not only hydrostatic pressure come with an extra amount of blood, there is also increased protein. So edema should not be formed. I agree with him. When you do exercise, you develop more blood going to muscles. But muscles don't become edematous. They only become hyperemic. They don't become edematous. Edema will only develop when these balance between these two hydrodynamic forces is significantly disturbed. You are understanding? So only increase arterial blood flow up to a limit, cannot produce edema. Is that right? Even when when hydrostatic pressure becomes so much that fluid which is going out becomes slightly increased, still not edema as safety factor by the lymphatics. Actually edema will form when so much fluid is, so much balance is disturbed, that too much fluid is coming here, and that extra fluid cannot be drained well by lymphatics, only then edema will develop. Is that right? Clear? Yes. Now we go back. So we were talking about pitting edema and non-pitting edema, right? So when hydrostatic forces are more and edema develop, or osmotic pressure is less and edema develop, this kind of edema is usually pitting edema. And classically, if there is long-term obstruction of lymphatics, then what kind of edema will be there? Non-pitting edema. Am I clear to everyone? Yes, sir. No issue at all. Why this is so important to know that a person has edema, is it pitting or non-pitting? Answer is very simple. The pitting edema if generalized edema is there, if it is pitting edema, it can be managed by diuretics. If you give the person diuretic, he will push more water out through the kidneys. If you produce more water out of the kidneys, what will happen? If through the kidneys you are getting more water out, eventually this water will suck back from here. But if there is non-pitting edema, if I have, okay, I'm the patient, here I have pitting edema and here I have non-pitting edema. If you give me diuretics, pitting edema will be reduced, but non-pitting edema will not reduce, because you can pull the water back into circulation and get the water out through kidneys by the diuretic drugs. Is that right? But in non-pitting edema, you don't have a drug to suck back the proteins and get them out into urine. So what did we learn? That pitting edemas better respond to diuretics, and non-pitting edema do not respond well to the diuretics. Here I want to highlight one more factor. That is about dependent edema. Another term is dependent edema. What is dependent edema? Yes, anyone from this line? Dependent edema. What is dependent? Have you heard of dependent edema?
Edema occurring in the depending part of the body, mainly feet and...
Very good. He is saying that as edema or swelling due to interstitial fluid increases in the dependent part of the body. Let's suppose if I have edema in my arm, right? If arm is like this, then my hand and lower part of the arm, edema will gravitate towards that. There will be more fluid here. But if I make it up, then edema will become less. Now, classically we say if someone has generalized edema all over the body, right? All over the body, the hydrostatic pressure is increased. Later on I will tell you it happens in heart failure, right? Now, if I have generalized edema and if I stand for a long time, then there will be more edema in my legs, ankles. That is called dependent edema. But with edema, if I keep on sitting, then more edema will be seen on my sacrum. And that is also another example, dependent edema. Dependent edema is actually that edema where edema fluid distribution is affected by the gravitational forces. Is that right? Lower part of the body gets more fluid. Why? It's very simple. Let's suppose all over my body hydrostatic pressure is high in all my veins. From lying down position, if I suddenly stand up, then it will be difficult for the blood to come back to the heart. So already there is increased hydrostatic pressure. Little more increase will listen. Let's suppose my arm is also edematous and my leg is also edematous, but both of them are edematous due to congestive cardiac failure. So due to increased hydrostatic pressure. Now do you think my arm is like this and leg is straight down, where will be more edema? In the leg. Why? Because from here fluid can easily come to the heart, right? So hydrostatic pressures will be still not so much, but from the leg hydrostatic pressure will be in lower part of the body too much, because gravity is trying to pull the fluid down, right, and body is trying to bring the fluid back to the heart, right, and that will gravitate the edema fluid to the leg. Now, to make the concept more clear about the dependent edema, to make the concept more clear, I will ask a question. Yes, this question is to our very brilliant student, Azaz. Normally, when you are lying down, you suddenly stand up. Does water redistribute and too much fluid go into interstitial fluids of leg? Normally. Yes, normally when you are lying down, suddenly when you stand up, too much fluid gravitate in the legs? No. If my arm is like this, do you think does it happen if I do like this, interstitial fluid will empty too much? Or if I go down, then arm size become double? Why it doesn't happen? First you understand this thing. Why it does not happen? It means normal body fluid distribution is not dependent. Normal body fluid distribution is not gravitational dependent, thanks God. Otherwise in standing position, lower part of the body will be heavy. I mean, on lying down position, it depends on you turn on this side, this arm will be double and this will be half. It doesn't happen, thanks God. Why it doesn't happen? How come that in a normal person with normal fluid in all body interstitium is not significantly affected by the gravity. Yes?
There is a reflex mechanism.
No, I will not go for that. I know he is going to talk about when we stand up, there is venous pulling in lower part of the body. I know what you are going to talk. I'm not talking about venous blood. I'm talking about interstitial fluid. I'm talking about interstitial fluid from lying down position. When you stand up, I agree. There is a tendency for the blood to pool in the lower part of the body. And when blood is pooling into lower part of venous vasculature, venous return to the heart decreases, cardiac output decreases, sympathetic overflow occur, and venules constrict and maintain the blood going back. I'm not talking about this, my friend. I'm talking a different question. I'm not talking about venous blood. I'm talking about interstitial fluid, this fluid. In normal person, from lying down position, this is my head. From lying down position, okay, let's take it like this. Red is the head. This person is lying down. If suddenly stand up, does all interstitial fluid tend to go down in the body? No. Why not?
Because the flow of the lymphatic is burning.
Okay, before you guys tell me very new theories, which are your personal theories, let me tell you the truth. It's a very basic concept. Our interstitial fluid, this interstitial fluid or interstitial tissue has lot of fluid holders. They have lot of fluid holders. Those are glycoproteins. Suppose this is a one glycoprotein molecule. It has lot of, this is one glycoprotein molecule. This is another glycoprotein molecule. Glycoprotein molecules have what? These are brush piles. What are these? Brush piles. Normally what happens? All your body interstitium is very, very rich in glycoproteins. You can say combs like this. This is one molecule of glycoproteins. You know, every tissue there are trillions and trillions of glycoprotein molecules. You know what is the purpose of these molecules? Have a lot of functions. One of the function is the small amount of fluid, that 11 liter of the fluid which is the interstitium, that is held at its place by these brush piles of glycoproteins. Am I clear? So what happened that when I raise my arm, all interstitial fluid will not drain, because the glycoprotein in interstitium which hold the water, they absorb the water and they don't allow too much movement of the water. You are understanding? This is the real reason that when you from lying down position, if you suddenly stand up, the glycoprotein in interstitium, they will hold the water and don't allow to gravitate it. Even though when air travel, your legs get swollen, or if you're sitting for a long time, it only happens when for a long time hydrostatic pressure becomes so much, it fails the glycoprotein mechanism. Is that clear? What holds the water in the interstitial fluid, tissue normally? That interstitial fluid is held in the interstitial tissue at its places by the glycoproteins. So small amount of water is coming, passing through the glycoproteins, very small amount of water, giving services here, removing the waste, going back or draining from here. Most of the water here is held with the glycoproteins. Am I clear?
Yes.
Any question up to this? Now imagine another thing. Normally, okay, let me show you. Here is a glycoprotein molecule and these are its brush piles, right? Now water, very small, very small bubbles of water, not bubbles really, very small amounts of water are held with this. This water which is held with these points, this is not free water. It is no free water. In interstitial space, mostly water is held with glycoprotein brush piles. What we call it? Glycoproteins brush. Brush always disturb me, you know, don't look at my head. Brush pile, yes. These glycoprotein brush piles, very bad, you are still looking at my head. Okay, no problem. Anyone who laugh at me, sooner or later they tend to lose the hair. Yes, you will see, inshallah, in coming years. Okay, now what I'm saying, that brush pile of glycoproteins is holding the water, right? very little water is coming, passing through it, percolating through, giving the services, going back. Clear? Now you imagine either hydrostatic pressure is too much or oncotic pressure is too less. Too much fluid is coming here. If too much fluid is coming here, it is another what is this molecule? Now, if excessive amount of fluid is coming here, it will separate the glycoprotein molecules and produce very small free water channels. Listen carefully. Normal person, in the interstitium, the amount of water, small amount of water, which is called interstitial fluid, that is held along the brush pile of glycoprotein. And there are very small, normally very small pockets of fluid, and fluid is not freely moving normally. But if there's too much fluid coming here, then what will happen? That some of the extra fluid will make a free channel. It will separate the glycoprotein molecules, in between a free channel will form. It is just like that you have sponge. You know what is sponge? Yes. Sponge. The sponge is holding the water, but if there's too much water, can sponge hold it? Free water will come. So these are the, you can say, interstitial tissue sponges. These are normally there, they hold the water. But when either there is, suppose, cardiac failure, right ventricular failure especially, all over the body, hydrostatic pressure in every capillary goes up and too much fluid come here, or there is severe decrease in plasma albumin, in that case also too much water here. In such kind of edemas, in such type of edemas, which is produced due to dearrangement of Starling forces, or which is produced due to dearrangement of hydrodynamic forces, or such edemas which are produced due to either increased hydrostatic pressure or decreased osmotic pressure, such edema fluid can become so excessive that it produces free water channels. When this free water channel is there, then gravity can play a role. If I have here edema due to increased hydrostatic pressure or edema due to decreased osmotic pressure, is that right? If my arm is like this, then edema will be in this area more and upper area less, because through the free water channels, gravity will affect and fluid will move. But if I take it down, then what will happen? Edema will again gravitate. So what happens? That in a normal person, fluid in the interstitial spaces is held, adsorbed along with the brush pile of glycoproteins, right? But in a person where there is excessive fluid in interstitial tissue, especially due to increased hydrostatic pressure or decreased osmotic pressure, this fluid separates the glycoprotein molecules and produces free channels of fluid, free water channels. In such patients, if patient from lying down position suddenly stand up, more fluid into lower part of the body, this is called dependent edema. Or if such patient is sitting for a long time, more fluid in the sacrum, that is dependent edema. So what is the mechanism of dependent edema? Mechanism of dependent edema, average doctor will say, simply when there is edema and gravity redistribute the edema fluid, and those parts of the body which are exerted more by the gravitational forces, they have more edema fluid. That is right answer, but a very good answer should be, because in lymphedema there may not be much dependent tendency. But in case of congestive cardiac failure or in nephrotic syndrome, which we'll discuss later, where plasma proteins are very low, edema becomes very dependent. It means distribution of edema fluid in such patient is very much determined by the gravitational effect. Why? Because free fluid is producing free fluid channels, and water can rapidly gravitate on the dependent part of the body. Any question up to this? But we will continue. Let's go back. I was talking about why the edema should be produced. One mechanism was increased hydrostatic pressure. Other mechanism I told you, decreased oncotic pressure. Third mechanism I told you, reduced lymphatic drainage, reduced lymphatic drainage or lymphatic obstruction. Then there can be other mechanisms too. Yes, anyone will tell me another mechanism? Increased fluid coming here, or decreased fluid sucked back, or lymphatic obstruction. Then there can be, if there is increased permeability. It classically occurs in inflammation. Increase permeability of microcirculation. Classically in inflammation, you know, when there is inflammation, if there is injury, right, in any tissue, inflammation develops. During inflammation, what happens? Chemical mediators are produced, which will increase the permeability of this. And when permeability of microcirculation is increased, even at normal pressure, it will allow more fluid to go out. But actually in inflammation, hydrostatic pressures also increase, right? But I will not talk about that. Simply I'm saying any pathological condition which will damage the microcirculation wall, or increase more interendothelial gaps. If endothelial cells which are holding with each other, they shrink their ends, then interendothelial gaps will develop. So whenever there is increased permeability of microcirculation, there is a tendency to develop edema. Am I clear? We'll discuss that again later into detail. And then another cause of edema is salt and water retention. Salt and water retention in the body. Due to any condition, like someone has a high level of circulating aldosterone, which will reabsorb excessive salt from the kidneys. If too much salt and water is retained in the body, my question is, if too much salt, whenever salt is retained, water tend to retain with it. If salt and water is retained in the body, it will produce interstitial edema or it will produce intracellular edema. Who will tell me? My question is, okay, I will give you a simple example. If you overload me, I'm a healthy person, if you too much overload me with normal saline, salt and water, more than what I can get out of my urine, if you are giving me that, too many changes will occur in the body. One of the change in the long run will occur that I will start developing certain type of edema. Now, if salt and water is retained in the body excessively, this will lead to edema. You will tell me it will lead to intracellular edema or interstitial edema or what?
Interstitial edema.
Why not intracellular?
Because it is isotonic.
Yes, both, you are wrong. Let me tell you, actually in this case, if there is excessive retention of salt and water, this usually leads to interstitial edema, not intracellular. But someone has to explain why not intracellular. Yes. Remember, actually, sodium, who loves to follow sodium? Water and negatively charged ions. Right now we'll talk about water. Wherever sodium goes, water follows. You understand few things in life like that. Wherever she goes, many follow, right? So what happens? Sodium is always followed by water. If there's more sodium, let's suppose I inject a lot of sodium here. Now sodium will come into circulatory system, but sodium cannot retain in circulatory system because capillary membranes are fully permeable to sodium. So if you give the sodium here, inject the sodium here, right? Whatever sodium is coming here, some of it will be stay in circulatory system, some of it will go out. But sodium cannot enter into cells. So what I'm saying, when you add the sodium to the blood, sodium will first enter into circulatory system and it can easily go from circulatory system to interstitial fluid, but sodium cannot enter into cell because cell membranes are not freely permeable to sodium. So barrier between the interstitial, barrier between the cell membrane is a barrier between the interstitium and cells. Sodium cannot cross it easily. But barrier between vascular compartment and interstitial compartment, it allows sodium movement freely. So what happens? If someone is getting too much sodium, it will hold the water, and wherever sodium goes, what will follow? Water. So sodium will come from here to here, so water will come here. And if it is not drained well, it will lead to edema. So it will lead to extracellular edema, not intracellular edema. You are understanding? So when you give lot of normal saline to a person, normal saline is being added to circulatory system if you are giving through intravenous, and then it is redistributing into interstitial fluid, but it is not entering into cells. That is why when normal saline or extra salt and water, when it is entering into interstitial tissue, it is producing edema, and when it is retained in circulatory system, it produces hypertension, high blood pressure. You are understanding? So what did we learn? We learned this thing, that excessive salt and water retention in the body, all those diseases will retain too much salt and water in the body, they have a tendency to produce edema also, but in such conditions there may be hypertension too, right? So let's come back. Hydrostatic pressure can produce edema by increasing the filtration pressures and decreasing the reabsorption pressure. Less osmotic pressure, if this is also smaller, again filtration is more and reabsorption is less. Or lymphatic drainage, again this drainage is impaired and fluid accumulates here. But here we have to remember, edema due to increased hydrostatic pressure or due to decreased oncotic pressure. The fluid which is retained here, it is without proteins, without additional proteins. So this edema is pitting edema, and this edema is dependent edema too. And lymphatic obstruction, especially at advanced stage, produces non-pitting edema, because here fluid is held along with the extra amount of proteins and fibrinogen and some growth of fibroblast and collagen. Then we are talking about in inflammatory conditions. If permeability of this membrane become too much leaky, also edema can occur. And then salt and water retention. I told you, if body is holding salt and water, all this salt and water cannot be held in circulatory system. As salt can freely move from circulatory system to interstitial system, this salt will bring additional water and may produce edema. Now, in next lectures, I will go in detail of what are the causes and mechanism of hydrostatic edema, and I will go in full detail of edema in patient with congestive cardiac failure. After that, we'll have another lecture. We'll talk about what are the diseases which produce oncotic, reduced oncotic pressure and edema, and especially we'll go into detail of edema in nephrotic syndrome and edema in cirrhosis. Then, of course, inflammation we'll discuss, and eventually mechanisms which retain salt and water. Any question up to this?
So what happens if we inject, rather than normal saline, some hypertonic solution?
Hypertonic solution, okay. If you inject some hypertonic solution, it depends on that solute which is there, can it go out of vascular system or not. Basic rule is this: whenever you inject the fluid, water follows the solute. Let me give you an example. If you give dextrose water, the glucose molecule which are coming into blood, some of them will stay in blood, some will come into interstitial area, but most of them will enter into cells. In that case, the water which came with the dextrose, that will distribute little here, more here, and mostly here. If you inject the salt and water, then salt will distribute into two compartments. Is that right? So when you give glucose, that will distribute in how many compartments? Vascular, interstitial, and intracellular. But because intracellular compartment is too big, and this is smaller and this is smallest, so water with glucose mostly will go intracellular and interstitial and very little in blood. You are understanding? But if you inject normal saline, salt, then salt will distribute in the body in vascular compartment and interstitial and will not enter here. So water which went with the salt will be retained in vascular system and interstitial system. But let's suppose you inject plasma proteins with water. If you inject plasma proteins, they will remain mostly in the circulatory system. So water which will go with the plasma proteins, that will be also mostly in the circulatory system. So basic concept I think one day I need to teach you surgery and the fluids on the surgical floors. But anyway, basic concept is that whenever we are injecting some body fluids in large amount, right? How the fluid will distribute, it depends on many factors. One of the factors is the movement of the solute. If solute can go to all fluid compartment, then water along with the solute will go to the all fluid compartment, right? Classical example is dextrose water, right? Then if fluid is going only to two compartments, like normal saline, if solute is going only to distribute into two compartments, water will also go there. Let me tell you, if you give 1 liter of dextrose water, now glucose will go into intracellular compartment, interstitial compartment and vascular compartment. So that 1 liter fluid will be diluted into all these compartments. So dextrose water cannot stay much in circulation. So it's not very good to support the circulatory system. Saline is better. When you give normal saline, 1 liter of normal saline, what will happen? 2/3 will come here, 1/3 will go here. Because normal saline, whatever salt water it has, they will distribute in these two. Is that right? So what will happen? In this case, normal saline, maybe out of 1000 ml, 600 ml will come here, or 700 ml will come here, and 300 ml will support circulatory system. But if you give 1 liter of fluid with plasma proteins, as plasma proteins will stay here, they will not go out immediately. So naturally then water will be staying here. That is why in a person, when person is going into shock after hemorrhage, dextrose water is not good. Saline is better, but plasma proteins are very good. And if you can get the blood, human blood, cross-matched, that is excellent. Because when you give the human blood, mostly the cells and proteins and other components stay in the circulation. So hold the water with it. Any more question?
Sir, if we give the patient normal saline, it will enter into interstitium. And sir, if the patient is running in sodium potassium ATPase pump deficiency or problem, will edema be compromised?
Okay, he has a question that if we give normal saline, the fluid will be distributed in vascular compartment and interstitial compartment. Then he came with some hypothetical situation that in some disease, if sodium potassium pumps in the body are not working at all, what will happen? Answer is, someone whose sodium and potassium pumps are not working at all will not take birth. We'll never have a patient like this until we give some toxic substance like ubane or some other substances which can really pump, paralyze all the sodium potassium pump. That will be a very big poison. Life is not possible without sodium potassium pump. Sodium potassium pumps are present and functional in every cell, including your cell and dog cells and rabbit cells and monkey cells. Right? Class dismissed. Thank you. Today we are going to talk about what is the role of increased hydrostatic pressure in capillaries in genesis of edema. Right? Let's go back and look at our basic diagram. That let's suppose here is your left heart and here is aorta, right? Arterial tree, and here lies your right heart system. Suppose it is a functional diagram, not anatomical, and here is caval system or venous system, and let's make a microcirculation of a part of a, this is arterial side, this is venous side, and from an isolated tissue, I have taken a piece of tissue. Let's suppose I make this tissue, okay, here. This is that tissue, right? And this was the arterial input into that tissue. And here is the venous drainage from that tissue, right? And of course, here should be lymphatics, right, which also drain the fluid back eventually to the venous system from these tissues. Now we start getting the basic concept as we discussed in the previous video, that let's suppose for understanding purpose, we say that microcirculation has an arterial end and microcirculation has an venous end, right? Microcirculation has arterial end, right, this side, and this part of the microcirculation is on the, yes, venous end. Now, what is the hydrostatic pressure in a typical tissue? Hydrostatic pressure in microcirculation. Let's suppose here hydrostatic pressure is 35 millimeter of mercury, and it is pushing the fluid outward. And here oncotic pressure, which is due to plasma proteins, especially albumin, oncotic pressure is 25 millimeter of mercury, which is trying to hold the fluid in. So balance of these Starling forces on the arterial end is that on arterial end of the capillaries, hydrostatic pressure is more. Hydrostatic pressure is also called hydraulic pressure. Hydrostatic pressure is more, and oncotic pressure is less. Oncotic pressure is the colloidal osmotic pressure exerted by the plasma protein, especially albumin, in the microcirculation. So oncotic pressure is less. So net filtration pressure is outward. Net filtration pressure is outward, right? This is our tissue. These are your cells. Very happy because they're also listening to the lecture. Now, so we can say on the arterial end of microcirculation, fluid is extravasating with approximately under the pressure of 10 millimeter of mercury, and constantly adding to the interstitial fluid. And on the venous side, oncotic pressure remain almost same. But as fluid moves through the microcirculation towards the venous side, right, hydrostatic pressure drop, and it is about, let's suppose, 15 millimeter of mercury. So hydrostatic pressure is now less, and on this side balance has become in the favor of inward. So net pressure across the semi-permeable capillary membrane is inward. We can say this is filter out pressure, this is reabsorption pressure, this is extravasation pressure, this is reabsorption pressure of about 10 millimeter of mercury. Plus we know that some proteins which may leak, they will be drained through lymphatics back to the circulatory system. Is that clear? Now I'm going to put a question to you guys, that this hydrostatic pressure depends, it is how it is generated in the capillaries. My question is now, how normal hydrostatic pressure in a typical tissue is created? What is the genesis of normal hydrostatic pressure, right? Yes, doctor.
Circulation.
Blood pressure, very right. Cardiac output and total peripheral resistance determine what is the pressure in arterial tree. What is the pressure in arterial tree? This pressure is transmitted in the microcirculation. So actually this is the cardiac output along with total peripheral resistance, which determines the blood pressure. Cardiac output into total peripheral resistance is equal to blood pressure. So blood pressure, arterial blood pressure, here is what? Arterial blood pressure. This arterial blood pressure, the pressure in the arterial tree transmits the pressure into microcirculation and produces, what is this? Hydrostatic pressure within the capillaries. Is that right?
Yes, sir.
After knowing this thing, now we come to another situation, that let's suppose a person's blood pressure goes up. A person whose blood pressure was 120 by 80 millimeter of mercury. This is a blood pressure of a person, 120 by 80 millimeter of mercury, and due to some reason, just for a short duration of time, maybe that person got excited, maybe that person got angry, maybe that person was under some kind of stress, blood pressure goes up. And let's suppose his blood pressure becomes 170 by 110. So this person, blood pressure goes up. If this blood pressure goes up, what will happen to the hydrostatic pressure in the capillaries? Right? Yes. What will happen to the hydrostatic pressure in the capillaries? Yes, doctor. Yes, you are saying that if blood pressure goes up, as blood pressure is the major determinant of hydrostatic pressure in capillaries, so when blood pressure goes up, I'm not saying, he is saying that hydrostatic pressure should also go up. Yes, and if hydrostatic pressure goes up, what will happen? Let's suppose hydrostatic pressure goes up 20 degree. So 35 plus 20, 35 plus 20 units, right? And also here 20 unit. We are hypothetically talking that if someone's blood pressure goes up, my friend is saying that if blood pressure goes up, then hydrostatic pressure in capillaries should also go up. And if hydrostatic pressure in capillaries goes up, then what will happen? That forces moving the fluid outward will be stronger. So you feel filter out will be more, yes, and filter back will be less, and edema will be produced. But actually edema does not produce. But in fact, in clinical practice, if someone has blood pressure going up without cardiac failure, I'm talking about just an episode of high blood pressure. A simple episode of high blood pressure does not lead to edema. Is that right? If cardiac function is... Now, question is that why it does not leads to edema? Answer is yes, please. Question is to you. My question is very clear. Listen. My question is that in day-to-day life, even in a normal healthy person, blood pressure fluctuates. If whenever blood pressure goes up, if with rising blood pressure, immediately if there is rise in the microcirculation pressure, that will favor the edema. But in real life, thanks God, it does not happen. Why it does not happen?
So because that is resultant is zero.
No, you are trying to confuse me. Anyone who is, yes. You understand what I'm saying? My question is very, very simple. When blood pressure goes up, right? Why edema does not occur? Because in all people who have clinical practice, they know that blood pressure goes up. If cardiac function is okay, edema does not result. Answer is this. Now listen very carefully. Answer is this. Wow. Just before the, what is this? Capillaries. There are special type of group of smooth muscles here. This is called precapillary sphincters. What are these? Precapillary sphincters. Before every microcirculation, there is a regulator. What is this? There is a regulator. It's very important to understand. All microcirculatory beds have a regulator at the input level on the arterial side. These are called precapillary sphincters. Sphincters just before the capillary network. And these are wonderful sphincters. You know what they do? When blood pressure goes up, they constrict, they become tight, and don't allow the excessive blood to come into capillaries and produce increased hydrostatic pressure, and don't allow the edema. Listen carefully. In all our body, right, there are precapillary sphincters just before microcirculation. These are the regulators. These are the regulators. Whenever blood pressure goes up, they become tight so that too much blood does not enter here, too much pressure does not come to microcirculation, and fluid exchanges between the vascular compartment and interstitial compartment is kept stable. Is that right? This is the right answer, that whenever there is transient fluctuations in the blood pressure, whenever there is transient fluctuation of the blood pressure, with every episode of blood pressure going up, does not produce increase hydrostatic pressure. So this is not going to be there. Blood pressure is there, but it will become tight and it will not allow extra hydrostatic pressure here. Is that right? And this is what prevents the edema in day-to-day life, that minute to minute sometimes our blood pressure is going up and down, but we are not repeatedly developing edema. Is that clear?
That's right.
Now another thing. When blood pressure goes down, sphincters relax. When blood pressure goes down, these sphincters relax. So they increase more pressure to come here to stabilize the fluid exchanges. So what is there? That on the arterial side of the microcirculation, there are very powerful regulators. These regulators are precapillary sphincters. Blood pressure goes up, they become tight and don't allow in microcirculation hydrostatic pressure to jump too much. And when blood pressure goes down, they become relaxed and don't allow the hydrostatic pressure in microcirculation to fall too much. Is that clear to everyone?
Where does come instruction to constrict?
Yeah, Dr. Saab is asking, who tells this that when blood pressure is high to constrict, right? The reason all the smooth muscles are connected with each other, right? Number one. Number two, neurohumoral mechanisms. Number three, local waste metabolic products. So there are multiple reasons how they are regulated. The simplest explanation is myogenic response. Myogenic response is as soon as pressure goes up, that will stretch the sphincter. Now listen carefully. He is asking, who tells sphincter that blood pressure is high and they should constrict? Now I'm going to answer this. There are multiple answers because there are multiple mechanisms. But one of the important mechanisms is myogenic responses. What is myogenic response? As soon as high pressure comes, this will be stretched. When they stretch, let's suppose this is a smooth muscle. There is out of this circle, this is the sphincter, and there is a smooth muscle in this. What is this? Smooth muscle. There are smooth muscles in that. Agreed?
Yes.
When more pressure will come, smooth muscle will stretch. When smooth muscle will become from this size, they will stretch. They have calcium channels. They have calcium channels. Calcium channels will also stretch, and there will be more calcium influx. And this calcium which goes in will lead to the smooth muscle constriction. Is that clear to everyone? Yes. So what happens? This is a great, just a minute. This I know I'm giving too much detail, but this is important for doctors and medicos to understand that blood pressure, day-to-day fluctuations, especially when it goes up, does not lead to edema, because microcirculation in the beginning has precapillary sphincters, and whenever pressure is more, these smooth muscles in the precapillary sphincters are stretched. Their calcium channels open more, and more calcium influx lead to constriction, and that constriction regulates the input of blood volume and pressure in microcirculation. Yes, you have a question.
Sir, how these sphincters are affected in cardiac failure?
We'll talk about that later. He is asking that how these sphincters are affected in the cardiac failure. Later on, we are going to have a full lecture today that what is the genesis of edema in cardiac failure. Now we come to another thing. That if there is, now you understand, if there is extra pressure coming from this side, if there is extra pressure coming from this side, it will not produce edema. Is that right? It's clear to everyone? Yes. Now, let's suppose if right heart fails, or there is some compression here, then pressure will come backward. Central venous pressure will go up. Again, I will tell you, what is the function of right heart? To pump the blood into lungs. Microcirculation of lungs, that is pulmonary circulation. Right heart pumps into lungs, and from the lungs, blood gets oxygenated and goes to the left heart. Is that right? Pulmonary circulation. Let's suppose that due to some reason, right heart is not pumping well. Blood is coming to the right heart, from the body blood is going to the right heart, but this pump is failing. It is unable to pump due to any reason. It cannot pump forward. So what will happen to the pressure in this area? It will go down or up? It will go up, of course. There will be back pressure. It will go up. If this pressure goes up, in central venous, pressure goes up. What will happen to hydrostatic pressure in microcirculation? Yes, dear. My question is, due to any reason, first I talked about if arterial blood pressure goes up, it does not lead to edema. And we talked about precapillary sphincter, which are the regulator here. Now we are talking about venous side. That due to any reason, if pressure in the venous side goes up, for example, right heart is not pumping well due to any reason. If right heart is not pumping well, blood is coming to right heart, but it cannot move forward properly, the pressure in the central venous system will increase. Will that increase the hydrostatic pressure in microcirculation or not?
If there are no sphincters, then of course hydrostatic pressure will increase.
Okay, what about you?
So I think there would be post-capillary sphincter which will prevent it.
Okay, he thinks, one of my very good student, decent, loving person, but always saying something unusual. He's saying that if central venous pressure goes up, then of course back pressure will come. Chances are hydrostatic pressure will go up. Then my friend told that there should be post-capillary sphincters too. There should be post-capillary sphincters too. This is his idea, not mine. He thinks that there should be post-capillary sphincters there and they will constrict and don't allow this pressure to go back. You are wrong. There are very powerful precapillary sphincters, but post-capillary sphincters are not very efficient and really not there, I should say. Or if they are there physiologically, they are very weak. So we can say that microcirculation on arterial end is having strong regulators, but microcirculation on the venous end is poorly regulated. The point to remember is microcirculation on the venous end is poorly regulated. I will give you an example. Every tube in the body does not have sphincters on both sides. Look at your mouth. You don't have sphincter here. You can open whenever you want. But other end has sphincter, right? So what I'm saying that every tube in the body does not have sphincter on both sides. And microcirculation has sphincters tight on
One side.
arterial side, but not on the venous side. That is why when central venous pressure goes up, back pressure will come and hydrostatic pressure in microcirculations go up, and that produces edema. That produces edema. So today's, up to now, what did we learn? Listen carefully. What did we learn? That hydrostatic pressure, if hydrostatic pressure in the microcirculation goes up, then more fluid will come out and less fluid will go back to the circulation. So edema will be produced. But we need to remember that if pressure goes up in arterial tree, does not produce edema because of precapillary sphincters. Due to precapillary sphincters, pressure going up on arterial side does not take the microcirculatory pressure significantly up. So thanks God there is no edema. But when pressure goes up in the venous system, then back pressure will come. Back pressure will come as venous end of microcirculations do not have very good regulators. They don't have specially designed post capillary sphincters, not as powerful as precapillary sphincter. So whenever central venous pressure goes up, right, that will transmit the pressure backward and definitely increase hydrostatic pressure. And when hydrostatic pressure will go up, that will favor the movement of fluid from vascular compartment to interstitial compartment, and that can initiate the process of edema formation. Am I clear?
That's right.
Any question up to this? Done? Okay. Now I have another question. In the very beginning of the one more question. If someone is standing like this, let's suppose I'm standing like this, and suddenly I undergo massive myocardial infarction, global myocardial infarction, and my ventricles fail to pump, right? Do you think I will immediately develop edema or not? Question goes to that lady. Yes. Yes, I will not. Why? Okay, this is right, she's right in this thing, that if I'm standing here, I go into cardiogenic shock. Of course, after that I will not be standing, but anyway, if I'm going to cardiogenic shock, if I go into cardiogenic shock, will I develop edema or not?
You will not.
I will not. Why I will not develop edema?
Because the strong precapillary sphincters are not involved.
You have your own theory. Anyone else?
So, lymphatics will try to compensate.
You have super, yes.
Circulation
Wow, that is the answer. If there is cardiogenic shock, whole circulatory system, if pumps are not pumping, throughout the circulation pressures will fall. From where edema will come? If throughout the pressure fall on arterial side and in capillaries, edema cannot come. Right? How edema develops in heart failure, we'll discuss after some time in detail. Now we come back. Once you have had these basic concepts, now we start talking about that what could be the causes of increased hydrostatic pressure. What could be the causes of increased hydrostatic pressure? I'm going to make this diagram again. This is arterial side, yes, and here it is capillary venous side, and there is venous outflow and central venous system going to, and here is your which heart? Right heart. Now, edema. I'm going to contradict what I said in previously, but I will explain why. Edema will occur whenever hydrostatic pressure goes up significantly, right? Now I'll go back. Due to any reason, if hydrostatic pressure become rather than 35, due to any reason, it has 20 units added. And here rather than 15, it has also 20 units added. So hydrostatic pressure in the microcirculation has gone up. And let's suppose that oncotic pressure is the same as normal, right? Now in this person, okay, first I add 10. First I add 10 units here and 10 units here. So hydrostatic pressure rather than 35 has become 45. Now pressure, the fluid will extravasate more or less? More. And fluid will reabsorb more or less? Listen, 25 is oncotic pressure and hydrostatic pressure on this end is also 25. Can it pull the fluid back? No. So actually reabsorption is reduced. So we have done, there is mild increase in hydrostatic pressure in this capillary circulation. Now extravasation of fluid is more and reabsorption of fluid is less. Will edema develop or not?
Yes.
Yes or not? Okay, people who believe edema will develop, raise your hands. I want to see their beautiful faces. Yes. Okay, and people who believe edema will not develop, raise their hands. It really depends on, it may develop or may not develop. It depends on one more player, that is the lymphatics. Lymphatics. Now listen carefully. When more fluid is moving out and less fluid is being reabsorbed, then fluid in this area become less or more? More. Right? If this fluid become more and all additional fluid, there is normal fluid which is coming in and reabsorbing. But if all additional fluid can be successfully drained by lymphatics, edema will not develop. This is a very important concept. What I'm saying, if there is increased hydrostatic pressure, due to that reason, extravasation of fluid is more, reabsorption of fluid by microcirculation is less, then additional fluid which is here, will it produce edema or not? It really depends on the performance of lymphatic drainage. It depends on performance of local lymphatics. If additional fluid is well drained by lymphatics And lymphatics can increase their fluid drainage capacity 5 to 10 times. If lymphatic system is working well in a tissue, it can drain extra fluid. If all the extra fluid which is coming due to this excessive hydrostatic pressure, if this fluid is drained by the lymphatics successfully, then edema will not develop. It means that in microcirculation, now listen with your both ears, everyone should have 2 ears, functional, listen now carefully. Edema will develop only when hydrostatic pressure becomes so high that extravasated fluid is so much extra that lymphatic drainage is overwhelmed. Only then edema will develop. I will rephrase it in another word, in simple words. Increased hydrostatic pressure brings more fluid into interstitial area. But hydrostatic pressure should be so much high that so much fluid should come that all extra fluid cannot be drained by lymphatics. Only then edema will develop. Is that clear? So simple little rise in hydrostatic pressure does not lead to edema. Is it clear? Now we come to the causes of edema. Causes of edema due to raised hydrostatic pressure. Number 1. Increased hydrostatic pressure due to arteriolodilation. Arteriolodilation. I told you that there were precapillary. Yes. Sphincters here. I told you there are precapillary sphincters. If we fail these sphincters, now listen carefully. If we fail these sphincters, then extra blood will come here and extra pressure will come here. Then edema can be produced. Classical example of this is if one part of the body is overheated. If heat is applied for long time, part of the body, then that heat will dilate precapillary sphincters and extra fluid will come and extra pressure will come and local edema will form, because edema will only form into that microcirculation and around that microcirculation where heat was applied. So this is an example that if there is too much arteriolodilation, that may lead to edema formation. Classical example is application of heat on some part of the body, right? But don't burn. I'm saying simply heat.
Something is quite near to burn, it's got reddish.
Yes, erythema.
Erythema or reddish जो है ना, it means it is there.
Yes, he is right that when there is too much heat, that area will become red, hot, swollen. It will become red due to increased inflow of the blood, erythema. It will become hot, this area will become hot because it is receiving heat externally, and internally also increased blood flow, bring more temperature there, heat. Thirdly, it will become swollen because precapillary sphincters fails and excessive fluid and pressure come here, and so much fluid may come that local lymphatics cannot drain well. The accumulated fluid will lead to swelling of the tissue. Is that right?
Yes, sir. Yes.
Then I will not go into detail, but I will just mention that arterial dilation, once I mention heat, and other I am going to mention, yes, neurohumoral dysfunction. Neurohumoral dysfunction may logically dilate and produce localized edema in some part of the body. Classical example is in angioedema, where if there is pathological dilation of, what is this? Precapillary sphincters, but angioedema has multiple mechanisms because there is increased permeability too. Both of them lead to the edema. But these sphincters are very tightly regulated by sympathetic nervous system. These precapillary sphincters are also regulated by sympathetic input, norepinephrine and epinephrine dependent sphincters. If those humoral mechanisms, they are also controlled by angiotensin 2, and there are other factors too. So if those neurohumoral mechanisms which control these sphincters, if in some part of the body, those neurohumoral mechanisms which control the regulators, those controllers fail, then regulators fail, that may produce localized edema, right? But these are less common situations.
Excuse me, just a little bit of sensitive information. There is some drug who can fail this sphincter to work.
Yeah, there are many drugs which can fail the sphincter, like hydralazine, right? There are many drugs which can fail the sphincters. That is why, as a side effect of hydralazine, you may have edema, ankle edema, or there are many drugs which are very strong, you can say, relaxer of the precapillary sphincters, right? They can also produce localized edema, some part of the body, as a side effect. Now we come to venous end. Most of the time, edema is produced due to raised pressure on the venous side. Now, if due to any reason this venous outflow is reduced, blocked, pressure will go up, excessive fluid will come out, and if it cannot be drained well by the lymphatic, edema will result. Now, some local causes of, what could be the local causes? First of all, external pressure on a vein. If vein is pressed from outside, as sometimes children put a rubber band on the hand, you put a rubber band, this will compress the veins but not compress the arteries, which are high pressure system. If veins are compressed, arterial blood will move into hand but cannot drain back properly, and capillaries of the hand will have high pressure. And when capillaries of the hand will have high pressure, more fluid will extravasate, and that will lead to edema or swelling of the hand. So this is one example.
The knee pad is very common complaint.
Yes. Another, on the clinical side, doctor is mentioning that if someone applies a knee pad very tightly, right? If it is applied tight, then arterial blood is going to the lower part of the lower limb, but venous blood cannot drain well. Then pressure in the microcirculation of lower leg will increase, and that will lead to edema. So external pressure on the venous system can produce localized edema. Is that clear? Then another example is, yes, if there is thrombosis, right? If a vein is blocked due to thrombosis or thromboembolism, if a vein is blocked, can fluid drain properly out?
No.
If fluid cannot drain out again, pressure will go up and chances of producing edema. So edema can be produced by increasing the venous pressure. Venous pressure can be increased locally by external pressure, or can be increased locally in some microcirculation due to formation of thrombus. The classical example here is deep venous thrombosis in lower limb. Deep DVTs, deep venous thrombosis, that actually blood clots intravascularly within the veins of the leg, right? In that case, arterial side is taking the blood to the leg, but venous side is not draining well, and that may lead to swelling of the limb. Is that right? So, okay, by the way, what is the difference in thrombus? There are 3-4 terms I want you to be clear. Number one, what is platelet adhesion? What is platelet aggregation? What is platelet plug? And what is thrombus? Yes, these are the terms. What is platelet adhesion? What is I'm asking 4 questions to you, rather I should ask 5 questions. Thrombus trigger me to that side. What is platelet adhesion? What is platelet aggregation? What is platelet primary platelet plug? And what is thrombus? And what is coagulation? Someone should be able to differentiate these 5 terms. Raise your hands. Okay, one person has one hand. Anyone else has hands? Yes, I should remind you, everyone has 2 hands. Raise your hands who really knows very clearly the difference in platelet adhesion, platelet aggregation, platelet plug, primary plug, coagulation, and thrombus. Yes, ma'am. Have you heard of these terms?
Yes.
But do you know how they are different? At least tell me they are different in spellings.
Yes.
Yes. But any other concept better than this?
When platelet comes and just attached to endothelium, it is adhesion.
Mhm.
When more platelet comes and join that platelet, it is aggregation.
Very good. Let me explain what she is saying. Let's suppose this is your endothelial cells, right? These are endothelial cells which are injured. These are endothelial cells which are injured. When platelet first time come and stick here, these platelets are sticking to, they are sticking to, not to the platelet. This first layer of platelet is sticking to non-platelet surface. When platelets stick to non-platelet surface, we say there is platelet adhesion. Right? What is happening? What is platelet adhesions? That if this is board, white board, if 4 boys come and stand here, this is boy adhesion, right? This is boy adhesion. In the same way, when platelet, boys are like platelets. When platelets stick to the non-platelet surface, they are called platelet adhesion. Okay, you come here. 3 boys I need here. Rapidly, rapidly. Let's suppose this white board is what? Endothelium, injured endothelium. Now this platelet come and stick here. Yes, another platelet come. 2 platelets. Now these 3 platelets which are sticking with the endothelium or subendothelial exposed collagen, injured, these platelets are sticking to this surface. We say this is a process of platelet adhesion. Now another boy come. Yes, you come. No. You stick to this boy. Oh, okay, you face there, so no risk. Yes. One more boy needed. Yes, please come. I'm not going to call girls. Relax. Okay. Now the second layer is platelet aggregation, because platelets are now sticking to the platelets.
That's right.
Right? So when first layer, when platelets stick to the non-platelet surface, platelet adhesion. But when platelet stick with each other, this is platelet aggregation. And then become more platelets. Yes, come. Yes, more platelets. If too many platelets come and stick with each other, and why more platelets are coming? Because the first platelet, when they arrive and stick, those platelets are activated and they release the substances which call more platelets. So more and more platelets are coming, and these platelets are getting attached over here. When too many platelets are collected, right, we say this is primary platelet plug, right? But when this primary platelet plug convert into thrombus, yes. Anyone? Yes, Dr. Saab. When we say that this primary platelet plug become a thrombus, no idea. Okay, listen. Listen. Collagen doesn't come here. Just a minute. Now when platelet plugs are attached here, you activate your hands like this. Yes, activate your hands like this. These are activated platelets. Activated platelets, what comes? That coagulation factors come, touch them, and coagulation factors become activated. Coagulation factors are basically proteins. And the final result of that coagulation factor is that activated coagulation factor eventually converts soluble protein fibrinogen into fibrin. And fibrin strands will come over here. What will come? Fibrin strands. All these boys are tied together with ropes, chains. So what happened? In the blood, there were proteins going, coagulation proteins. I will not go into detail. When they are caught by the activated platelets, and those proteins start converting fibrinogen into fibrin. Fibrins are the strands. They are strands. And those fibrin deposition will help these platelets to stick with each other. In a way, over all these boys, we throw the net of fibrin. This process, conversion of soluble fibrinogen, the process of converting soluble fibrinogen into insoluble fibrin, that process is called coagulation. So what happened? First platelet adhesion, then platelet aggregation and activation, then coagulation, and when platelet plug plus coagulation, that is called thrombus. So what is thrombus? Thrombus is when within the circulatory system somewhere platelets undergo process of adhesion, aggregation, activation, and make a platelet plug. And once this plug is formed, on the top of that plug, if fibrin deposits, we say platelet plug has which process? Coagulation process. And this platelet plug plus coagulated fibrin, these together make a thrombus. Please, thank you. Go back to your seats. So anyway, I will not go into detail further. You know the difference. Platelet adhesion, platelet sticking to non-platelet surface. Platelet aggregation, platelet sticking to each other. Platelet plug, when lot of platelet are sticking together, activated, and they undergo certain morphological changes and making a unified mass. That is primary platelet plug. At the top of that plug, if coagulation process deposits the fibrin, that is coagulation. Then platelet plug plus coagulation together make the thrombus. And if that thrombus which is formed here, it detaches from here, it break away and start moving here, then this thrombus is called embolus. When thrombus break away and moves like an embolus, then it is called embolus. And because this thrombus keep on moving and goes in some other part of the vascular system and plugs that. For example, if this thrombus detached from here, it kept on moving and blocked this area. We say this part of the vascular system has undergone the process of thromboembolism. So you understand, thrombus is until it is attached, and if it is freely moving, it is embolus. And when it reaches to new place and block, we say a thrombus which become emboli has blocked. When blockage occurs, then we say there is thromboembolism. Let's go back. So we were talking about the raised pressure in microcirculation may lead to increased hydrostatic pressure, excessive oozing of the fluid, right? And this excessive fluid, if it cannot be successfully drained completely, extra fluid staying here will produce edema. And local causes of edema were on the venous side, external pressure or thrombus formation, right? Then local pressure can you tell me some other cause of the local pressure? Especially lower limb inactivity and prolonged dependency. For example, when you have 12 hours flight, if you are keep sitting in a long haul flight, you keep sitting, then what happens? That the venous return from the lower limbs to the upper part of the body become less. Because when you are sitting, you are not moving your muscles. Usually, lower part of the body, around the veins, there are muscles like soleus and other. And muscles in the limbs contract and help the veins to push the blood back to the central veins. But when lower limbs are inactive, and they are dependent for a long time, then what happens? Two things happen. Number one, hydrostatic pressure in dependent veins of the lower limb increases, right? There are no postcapillary sphincters which are very effective, right? So that will lead to edema, and prolonged sitting may also predispose the person for thrombus formation. Is that right? So these were local causes of edema. These were the causes of localized edema due to increased hydrostatic pressure, or arterial side, local heat or neurohumoral dysfunction. On venous side, local causes are what? Yes, external pressure or thrombus, or prolonged inactivity of lower limb and dependency of lower limb, as it happens in very long flights. There actually you are advised to that you stand up in the plane and little bit walk after some time, right? After this, we come to causes of increased hydrostatic pressure in the capillaries, generally, not local, which produce generalized edema. For example, in cardiac failure, if someone has heart failure, let's suppose someone has right ventricular failure, right? Blood is not going forward, pressure is accumulating here. From here blood is coming into circulation, but from here it is not going back. If right ventricular failure occur, what will happen? Central venous pressure will increase, and all the capillary beds pressure will be increased. You are understanding? Not localized. All the capillary bed number 1, bed number 2, bed number 3, so it means multiple capillary beds in the body. When central venous pressure goes up, I'm talking about central. Previously I was talking about local venous pressure going up. Now I'm talking about central venous pressure goes up due to any reason. If it goes up, especially in cardiac failure or constrictive pericarditis, or in splanchnic circulation, portal hypertension and cirrhosis, when central venous pressure goes up, that produces generalized edema. And we will discuss that after the break. After the break, I will specially discuss the genesis of edema in cardiac failure, right? Let's have a break.